அண்ணா சொல்லுங்க.
அதான் திடீர்னு இன்னைக்கு பேசவே முடியல பார்த்தேன் நான்.
சாரிண்ணா, நானும் ரொம்ப பிஸி இன்னைக்கு.
இல்ல, இன்னைக்கு எங்களுக்கு இங்கே பயங்கர பிஸி.
உங்களுக்கு அந்த இது ஆர்கனைசிங்ல போய் இது பண்ணிட்டு
ஆமா,
இருந்தீங்கல்ல.
நாளைக்கு வரைக்கும் மீட்டிங் வேறங்க. எக்ஸாக்டா 5:30 வில் ஸ்டார்ட்டுங்க. ஓகே, ராஜ்குமார், ப்ரேயர் ரெடி பண்ணிக்கங்க. கீப் இட் ரெடி. வில் ஸ்டார்ட்.
ஓகேங்க சார்.
திரு நர்மதா, லேட்டான யூ ஜாயின், ஸ்டார்ட் பண்ணிடலாம்.
திரு குட் ஈவினிங். ராஜ்குமார் குட் ஈவினிங்.
சார் குட் ஈவினிங் கோபால் சார்.
வணக்கம் தரேன். சாரி. Another minute and then we'll start, sir.
Yeah.
Gar velo kano.
அவர் டிராவல் பண்ணிட்டு இருக்கார் சார்.
Yeah, must be.
இல்ல சார், இஸ் இன் எங்க இன்னைக்கு மைசூர் அந்த இந்த
Yeah, I
காவேரி
understand.
பெடிகான்
Yeah.
மகாகாவுமா சம்திங் அதுல இருந்து வந்து.
We can start through.
Okay அண்ணா.
Start.
Good evening everyone. It gives me great pleasure to be part of today's evening CME. During the COVID time, we have had plenty of CMEs almost every week, and nowadays we have moved on to single session programs. But today, as part of our Kongu Pedicon curtain raiser for Kongu Pedicon, we are having our Kongu Pedicon curtain raiser CME. Now I request our treasurer, Dr. Rajkumar, to start the program with the pediatrician's prayer. Dr. Rajkumar.
Yes, sir. Thank you, Thiru. Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good and accept within reason the things we cannot change. Grant us your blessings, grace and mercy in all situations, at all times and amid all people. Thank you. Over to you, Thiru.
Thank you, sir. Now I request our President, Dr. Rajendran, who is also the convener for Kongu Pedicon, to inaugurate today's curtain raiser CME.
Thank you, Dr. Thiru. And at the outset, I thank the Kongu Pedicon team as well as IAPT and together we are organizing this curtain raiser CME. And most respected our President 2024, Dr. Balashankar, and President-elect Dr. Somasundaram, Vice President Dr. Gopal Subramaniam, and Secretary Dr. Narmada, and Dr. Rajkumar, Treasurer, and our scientific advisor and Dr. M. Singarvel, sir, and academic coordinator Dr. Thirumurugan. So on behalf of IAPTNC, very welcome. And I welcome the Kongu Pedicon organizing team, organizing Chief Organizing Secretary Dr. Muhammad Ismail, and Chief Organizing Secretary Dr. Sasikumar, and Treasurer Dr. Malay Balaji. And I welcome today's chairpersons, Dr. Nandini Kumaran, Dr. Jalil Ahmed, Dr. Jayavardhana. And resource persons are club of most talented faculties, renowned faculties also. Dr. Mageshwari sir and Dr. Baldev and Dr. Paramanand Dangar and Obama and Dr. Swadi and as well as Anurag. So these are most vibrant as well as talented faculties. I think today the CME will be mixed with newborn as well as emergencies and even power observation by Dr. Baldev sir. And definitely it will be start with newborn, it may end up in the emergencies. On behalf of IAPTNC, I once again welcome all the delegates as well as on central as well as state EB members. Thank you very much. Thank you.
Sorry, thank you very much, sir.
Good
Now
evening
I
to all.
request.
Good evening to all.
Yes, sir. Good evening, sir. Good evening, sir.
Good evening, sir.
Yes,
Good
sir.
evening, sir.
Yes, sir. We request our scientific advisor and of our IAB Tamil Nadu and also the scientific advisor for the Kongu Pedicon, Dr. Singarodu sir, to say a few words. Singarodu sir.
Thank you, Thiru. Good evening to all. The most respected dynamic President Rajendran and President-elect and past President Secretary Namada and Vice President and our chairpersons today and all the speakers who accepted our invitation in a very short notice. Our President and our academic coordinator and our team secretary planned to have a program as a CME program prior to the conference to deliver very important topics to our delegates and postgraduates who have joined in large numbers in our this not in a Zoom platform, they are in YouTube platform, and I'm happy that this program will be definitely useful to all our practitioners and our postgraduate, and all the speakers are relevant speakers and great academicians, and it is a mixed bag CME which we planned in a very short time. It has come out very well. I'm surely that all will be benefited. Though I am traveling outside our place, I'm happy that all the speakers who have accepted our invitation and to be here on this auspicious Sunday. Wish you all the best. Happy learning to all of it. Thank you for giving me this wonderful opportunity. Over to Thiru.
Thank you, sir. Thank you very much, sir. Now I request our Vice President of IAB Tamil Nadu, Dr. Gopal, to say a few words.
Thank you, Thiru. Respected President, Secretary and Treasurer of IAP Tamil Nadu. It's a great occasion today. We are having a Kongu Pedicon curtain raise in CME. On behalf of IAP TNSC, I welcome you all for this wonderful learning session. And I'm sure that this session is going to be a hit among postgraduates. Once again, thank the organizers for including me into the team. Thank you.
Thank you, sir. Now, I request the organizing secretary of the Kongu Pedicon, Dr. Shashi, to say a few words. Dr. Shashi.
Good evening, respected Tamil Nadu IAP President Rajendran sir, Secretary Narmada Madam, immediate past and future President-elect, and all the senior professors and dignitaries, Central EB member Ismail sir, and our scientific advisor Dr. Singarwalan sir. And on behalf of Kongu Pedicon organizing team, I welcome you all to Coimbatore, and I thank all the faculties who have accepted to give this wonderful CME, and hope we all learn a lot from these stalwarts. Thank you for the opportunity. Again, welcome to Kongu Pedicon. Thank you, Thiru.
Thank you very much, sir. As our organizing chairperson, chief organizing chairperson, Dr. Ismail is here. Sir, just a few words before we move on. Dr. Ismail.
Thank you. Thank you, Thiru, President, Secretary, and the members of the IAPT NSC, and all the resource persons today, chairpersons of this program, and of course, all the delegates and my dear friends. It gives me an immense pleasure talking to you regarding the curtain riser for the Kongu Pedicon. As far as our team is concerned, we are making an excellent arrangements, and of course, our team is working hard to have a wonderful conference this year at Coimbatore. Of course, it will be a teaser for both the incoming National Pedicon in 2027 as well. So this CME is going to have a test of time, and it will really be a curtain riser for the Kongu Pedicon. I immensely thank all the speakers who had volunteered. I congratulate all the members who had really taken work hard for this. I wish success for this program, and I welcome you all to the Kongu Pedicon commencing on 15th of August this month. Thank you.
Thank you, sir. This CME was basically thought as a kind of a sample for what we can expect from Kongu Pedicon. For the first time ever, the Kongu Pedicon has got more than 180 speakers. This is the first time ever the Tamil Nadu, IAP Tamil Nadu state conference has got that many speakers. There are 3 halls which are going to run simultaneously on all 3 days. And we have got more than 25 national faculties, but we want to listen to more. So there are quite a few people whom we thought we should invite and make them part of our team, and then help have us enlightening us on various topics. So we have got some really experts, great experts from the various parts of the country to address us and then share their wisdom with us. So, and we have got 3 chairpersons for the day. The first session will be chaired by Dr. Nandini, ma'am. Dr. Nandini, ma'am, as we all know, is is one of the key components of the key persons of the Kongu Pedicon, and also she is a very senior pediatrician from Coimbatore. Over to her for the next session. She will be chairing the next 2 sessions. Dr. Nandini, ma'am.
Good evening. It gives me great pleasure to welcome you all to this curtain raising CME program of Kongu Pedicon, and I welcome all of you to Kongu Pedicon also. And today we have the first topic, which is going to be by Dr. Maheshwari, and this is going to be, as you know, Dr. Maheshwari is a retired additional director, MNH from the government of Rajasthan, and he's presently the consultant pediatrician in Varna, Rajasthan. And he has edited many books, and his topic
infant feeding
will be about infant feeding. And over to you, sir.
Madam, and added to that, Maheshwari sir, the most respected personality of IAPL, who connects the whole Rajasthan. Such a great, eminent person in Rajasthan who witnessed and seeing him there only will know about this. Thank you, Maheshwari sir, for readily accepting. And he has done lot of work in malaria. And wherever we go, his talk on malaria was very well appreciated. Thank you, sir, for accepting invitation. Thank you.
Thank you, sir, for including me.
So over to you, sir, for the talk.
Should I share the screen?
Yes, sir. Yes,
Yes,
sir.
sir, you can share, sir. Please,
Yes,
sir.
sir, you can
Please go
share.
ahead, sir.
एक मिनट आ जाए Am I audible?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. You are.
Yes, very clearly.
Screen
Make it full screen, sir. Make it full screen.
Make it full screen.
Slide. Okay, is it okay?
Yeah.
Yes, sir.
Perfect.
Yes, sir.
வணக்கம் உங்கள் அனைவருக்கும்
Yes, sir. Yes, sir. Yes, sir.
நல்லா மாலை வணக்கம். A very good evening to all of you.
Excellent, sir. Excellent.
இந்த வாய்ப்பை கொடுத்து தனக்கு தொடர்பல் ருக்கு நன்றி சொல்லுகிறேன். I am thankful to the organizers for giving me this opportunity. And Tamil உச்சரிப்பு தவறா இருந்தால் தயவு செய்து மன்னிக்கவும். Please excuse me if my Tamil pronunciation is wrong.
Wonderful, sir. Wonderful.
Wonderful, sir. Welcome, sir. Welcome.
So now coming to the topic proper, infant feeding. From many of us feel that to discuss about infant feeding does not make sense. But if we confront with the statistics that we still have a significant, very significant 2-digit neonatal mortality, infant mortality, under 5 mortality, and many of a significant number of our kids are stunted, we need to think. And if we analyze the region, the most common region is the poor IYCF practices. And that is why I have chosen this topic for discussion. The latest idea is to think about the first 1,000 days. And among these first 1,000 days, the first day is the day of conception. It is not the first day of missed period or not the first day after delivery, but it is the first day starts from the day of conception to the 2 years. So from 1,000 days, 280 days are of pregnancy, and remaining 670 days are of the 2 years. So the care of the child should start from the womb. And among these 2 years, first 2 years, the first year is very important because most of the brain development occurs in the first year of life. Roughly 90% brain development occurs in the first year of life. Malnutrition strikes the most in infancy, beginning in 3 to 4 months. And 10 lakh children die during the first month, or 14 lakhs die by the year 1, and 20 lakhs by 5 years. And 2/3 of these deaths are related to poor feeding. That shows the importance of this topic. Traditionally, infant feeding is divided into two parts, breastfeeding and complementary feeding. But this time I have gone slightly sideways and included pre-conception to delivery to accommodate the first 1,000 days concept. I feel that the crop cannot be good if the field is not correct, if the field is not proper to go with the crop. So pre-conception, the care of the care should start from pre-conception. Every medical checkup of every girl around marriage should be done. So we can exclude many diseases or like thalassemia, thyroid issues, blood sugar or diabetes, anemia, malnutrition, etc. And we should take corrective measures as applicable before she conceives, so that she does not get any issues during the pregnancy. She must be given guidance for changes occurring during pregnancy. She must be taught pelvic exercises so that she can easily undertake the vaginal delivery. Then she must be taught to have a healthy lifestyle and should be advised to have a proper diet. She must be given vaccination, especially about rubella and hepatitis B. The marriageable girl should be asked to avoid alcohol, cigarettes, etc. Family planning advice should also be given. And during the discussion, we may include family or friends. After she conceives or during pregnancy, again we should do counseling of the mother and other caregivers. We should explain her advantages of the breastfeeding as well as the colostrum feeding. She must get her breasts examined during the antenatal period, especially to see for retracted nipple, and sore nipples or breast abscess, etc., which are sometimes a common cause of lactational failure. We should train them for cup feeding, and we should ask them to avoid bottles feeding and pacifiers. We should also train them and teach them how to express milk, take care of anemia, diabetes, thyroid issues, etc. Emotional support should also be given. And moreover, most important is the husband should also be counseled. He should also be asked to support his wife for the whole pregnancy and afterwards. Now coming to the breastfeeding. Friends, breastfeeding is not just the first food. It is rather the first vaccine, the first emotional bond, and the first protection the mother gives to her child. We can save 1 million deaths per year if breastfeeding is started within first half hour to 1 hour of birth. And the biggest advantage of breastfeeding is it is specific. You can give protein, fats from outside in formula milk, but cannot give emotions. That is why mother's milk is also called as nectar or amrit. उसमें माँ का प्यार, मोहब्बत और वो जुड़ा हुआ है. That mother, there is an emotional bond between the mother and child which persists for whole life. What is expected? We want is that the mother should start breastfeeding as early as possible. And in any case, before 30 minutes of delivery. And nowadays, the concept is that the breastfeeding should start during the labor room. As soon as the mother is delivered, before the cord is cut, the child should be asked in prone position to lie over mother's chest. And once you make the child lie over the mother's chest, he slowly crawls and goes towards the nipple and starts sucking. This is known as breast crawl. We must continue, the lady must continue breastfeeding for at least 2 years. And breastfeeding should be stopped only if the breasts are dry or if the mother is pregnant again. Why do we ask for early initiation? A point which may come in our mind. Initiation of breastfeeding within the labor room is best, as at that time, unexpectedly, both mother and child are active. It sets the tone for breastfeeding success. It stimulates cholesterol production and is responsible for improved cognitive development of child. It has been proved in many researches that if the mother gives colostrum to her child and starts breastfeeding early, the IQ of that child is likely to be 8 to 10 points more than the other boys who have not received colostrum or the breastfeed or have received breastfeeding late. It builds skin-to-skin contact and emotional bonding and helps uterus contract and reduces the postpartum hemorrhage. So again, this slide indicates the importance of initiating early breastfeeding. If we start early breastfeeding within half to 1 hour, 22% newborn deaths can be reduced. See the importance just by starting the breastfeeding early. And the status is, in our country, 15 million newborns. Please see the figure. 15 million newborns in India are not breastfed in the first hour. This is a very big point, and we must all be attentive. We must prepare ourselves to address this situation. Now, the status of breastfeeding. If you see the NFHS 5th survey, early initiation of breastfeeding within 1 hour of birth is just 41.8%. And if I look to my state, the early initiation is 42%. Exclusive breastfeeding in my state is 64%. Friends, just see, the institutional deliveries are staggering. 90% deliveries are institutional deliveries. So the lady is in the labor room, lady is in the hospital, the child is delivered in the hospital, and still these figures, they cannot initiate, they are not initiating the breastfeeding within first hour. Exclusive breastfeeding is not given by more than 50% of the child. So this clearly shows that something is wrong with us also. This is the present status of breastfeeding. During the survey, DFHS survey, 4 to 5, 6 states, some states have improved, and in 12 states and union territories, breastfeeding rates have dropped. This is a cause of concern. We must take a pause and think how to reverse this situation. Why it is happening? We are going the wrong way. We are shifting from traditional home-based childbirth to hospital-based care, creating breastfeeding barriers. Gaps in the quality of care to mothers and newborns, shift from joint to nuclear family systems, increased availability and aggressive marketing of formula milk powder and their paid influencers, erosion of traditional practices in urban families, misconceptions among educated mothers, urbanization and technology distanced mothers from breastfeeding wisdom, and lastly, preference for painless deliveries, anesthesia, unwarranted episiotomies. These all contribute to delayed start of breastfeeding. What are the modern day challenges? There is high rate of cesarean deliveries delaying breastfeeding, separation of mother and baby in the hospital, limited lactation support services, and moreover, more and more mothers are nowadays working mothers. They get inadequate maternity leave. They have no dedicated nursing space, non-availability of creches, lack of supports and breaks to leave workplace in between for breastfeeding. How to assess whether the breastfeeding is going on normally or not? How should we convince mother? We should tell mother that if the baby releases the breast naturally and appears content and sleepy, everything is okay. If the baby takes slow, deep sucks, it shows good attachment. If the baby is quick and shallow sucks, it shows poor attachment. If the mother hears voice of gulping milk going down to the stomach, it's a good sign. And if the child finishes the feed less than 4 minutes, or if the child takes more than 30 minutes, it signals issues. We must interfere. We should look what are the issues. And post-feed behavior, its weight gain, etc. These all shows how to assess the breastfeeding sessions. And these are in this slide I have shown, there are some points which indicate inadequate breast milk indicators. Say if the weight gain initially is less than 20 gram per day, the baby uses less than 6 to 8 wet diapers per day, does not pass stool regularly, the stool quality is poor, the weight loss is more than 10% of birth weight, failure to regain birth weight by 14 to 15 days of life, not passing urine in first 24 hours, and clinical evidence that baby is dehydrated. More and more mothers, as I said earlier, are going to work. How should they make a balance between the work and breastfeeding? So we must ensure, impress upon them that direct breastfeeding is best. But if at all they have to go to work, they must breastfeed before going to the office and should feed the child as soon as they come to the home after office. They can increase the frequency of feeding in the early morning or evening and night feeds. If possible, if the home is nearer to their workplace, they can take their baby to office if the crèche facility is available. And if the home, their residence is near to their office, baby can be brought to workplace for feeding. They can ask for extended maternity leave or unpaid leaves, work from home, flexible work hours, breastfeeding. They can do breastfeeding while commuting, and they can use express breast milk. They can express their breast milk during the day, preserve it, and give it to the child next day. They can just form their own personal milk bank. But they should be told that once they express their milk and keep it in freeze or store them, it should not be boiled or pasteurized before using. Just it should be brought to the room temperature and it should be used. There's another 444 rule. This rule is for breast milk storage. It's a simple guideline for the new mothers, especially working mothers. It suggests that expressed breast milk can be safely stored at room temperature for 4 hours, in the refrigerator for 4 days, and in the freezer for 4 months. Duties of pediatrician. What, as a pediatrician, we are skipping, and how are we certainly really responsible? We are not practicing early skin-to-skin contact in labor room. Many times, our colleagues go for unnecessary admission in NICU of asymptomatic healthy infants, especially after caesarean deliveries. They are not giving first feed. They are giving first feed as formula milk as if it is a norm till the actual milk secretion starts coming. Preventable NICU admissions like significant jaundice requiring phototherapy, not in exchange range. They must motivate mothers for relactation in case of lactational failure. And the pediatricians must realize that they are not just treating a mother or baby, they are shaping the future of the nation. Role of obstetricians. They are also should be made responsible. They must be asked to do a proper antenatal counseling, and they must examine the breast always during the antenatal examination so that retracted nipples, sore nipple problems are solved. Preventing elective inductions or cesarean between 37 to 38 weeks wherever possible. Minimize use of drugs like oxytocin. Minimize episiotomies. Cesarean section should only be done wherever it is expressly indicated, and they must support early post-operative lactation. Then, many times the deliveries are attended by doctors across these specialties. And my message to them are, they must also advocate for lactation rooms and support staff access to the breastfeeding breaks. They must check lactational quality of medications. They can just go to the internet on the site of LactMed and see whether the drug which they want to give is compatible for the child or not. Avoid unnecessary cessation of breastfeeding for diagnostic procedures.
Dr. Sasi, mute the phone.
All specialties to encourage lactation-friendly environments in the hospital, educate families and bust myths. They should proactively debunk popular myths. The myth that formula is better for weight gain should be very well told to them that this is not good, this is not proper. Breastfeeding should stop if mother is sick. Again, this is not a rule. This is not a dictum. Small breast can't produce enough milk. Well, the size of breast has nothing to do with the quantity of milk. Anesthetists, they should limit perinatal drugs affecting newborn alertness and latch. Psychiatrists should address postpartum dementia while preserving breastfeeding. Breastfeeding during COVID. Should a COVID positive mother feed her child? Yes. She must wear a medical mask and maintain appropriate hand hygiene, follow COVID appropriate behavior. Government has also taken many initiatives like Laksh program, Ma program. The Laksh improves the labor room quality improvement initiative, and Ma program is for improving the breastfeeding or early breastfeeding. Every pediatrician or every doctor who attends the deliveries must once listen to the paper of Dr. Cicely Williams entitled Milk and Murder. She was the first Jamaican pediatrician who first described the hazards of the formula milk. She first described that the formula milk are in fact not improving the quality of the child. They are in fact the murderers. They murder the child. Now, coming to the second part, complementary feeding. After 6 months of age, when breast milk alone is no longer sufficient to meet his or her nutritional requirement, some liquids or food must be given to the infant in addition to the breast milk. It is the process by which the infant gradually becomes accustomed to the adult diet. This is a development period when it is critical for children to learn to accept healthy foods and beverages and establish long-term dietary patterns. It also coincides with the peak period for risk of growth faltering and nutrient deficiencies. The other reasons to start complementary feeding at 6 months of age are the child develops neck and head control and hand-to-mouth coordination. The child starts enjoying mouthing and biting. The intestines are mature and ready to digest pulses and cereals. Baby likes chewing and gumming semi-solids as there is hardening of gums and eruption of teeth. And he or she has a tendency to push solids out of mouth. The tendency to push solids out of mouth decreases. So what is the present scenario? Most of the time, complementary feeding are either started too early or too late. Complementary feeds are nutritionally inadequate. Food safety measures are hardly followed, and the mother as well as the caretakers have poor knowledge about its role. Infants grow at a very rapid rate and need complementary feeding, as I said earlier, as breast milk alone cannot sustain growth after 6 months. And most of the growth in the nervous system of the brain is complete in the first 2 years of life. Hence, we have to be very particular in these 2 years of life.
Akim sir, another couple of minutes, sir.
5 more minutes, sir. 5 minutes.
Yeah, I will try to finish. Should be rich in energy and adequate in quantity proteins, vitamin and minerals, should have soft consistency to enable the child to swallow, and should need minimal preparation. It should be given timely, adequate, safe and properly feed. Children who start complementary feeding at 6 months grow well. These are the hazards if we start premature introduction of complementary feeding or we start late. Food should provide sufficient energy, proteins and micronutrients. We should use animal source food also, like dairy products, fruits, green and leafy vegetables. We should use combination diets like rajma chawal and khichdi. These are three styles. This is the first controlling style in which the mother dictates and she force feeds her child, leading to the chubby child. But this child does not know how to recognize his appetite. This is just the reverse. The mother is not at all involved, the caregivers are not involved, and the child becomes malnourished. Responsive feeding, when the mother and father and the caregivers sit with the child and feed properly in a good way, is the best. Diet should be culturally and socially acceptable. This is the practical guidance on how much calorie the child needs and how frequent we should give him feeding. This is about the fluid drinks, whether should we give or not. We should avoid biscuits, ultra-processed foods, and bottle feeding. Another point, smartphones and infant feeding. It negatively impacts mother-child relationship with child's development. It distracts from the phone. Distraction from phone can interfere with the baby's latch, milk flow, and the crucial bonding experience that involves skin-to-skin contact and eye contact. It leads to decreased oxytocin release. The responsibility of father is equal to the mother. He must support and motivate the mother. So my carry-home message is all health personnel must know the importance of breastfeeding. Proper IYC practices are essential to the proper growth of the child with the nation. Thank you for a patient hearing. Thank you, sir.
Thank you very
Wonderful.
much, sir, for finishing
Wonderful
this
talk,
time
sir.
and a wonderful talk, sir. Wonderful talk. Starting from pre-pregnancy, as you said, the crop will not be good if the field is not of a good quality, with good quality soil. So you started from pre-pregnancy. Excellent, sir. Thank you for finishing
Dr.
the
Nandini,
time.
are we taking the chat box? There is one
No,
question in the chat box.
Yeah, please ask it.
Yes, yes. Hello, sir. Hello, question, sir.
Yes, sir. There, one
Maheshwari, sir,
question
congratulations.
is oxytocin is
Thank you.
required or indicated during lactation?
Pardon?
Is oxytocin is indicated in lactation period? That's what there was one question in the chat
No,
box.
it should not be given.
Should not be
We
given.
should promote breastfeeding and oxytocin naturally will be released.
How can using oxytocin affect the lactocin, sir?
Yes.
This was the question.
So they want to know how oxytocin can affect lactation.
Affect the lactation.
Oxytocin, in fact, improves the delivery of the milk from the channels. But
Yes.
external oxytocin is not required.
It.
Fine.
It's only ejection of the milk from the tubules.
Yeah. Yes.
Very rightly said, sir.
Thank you, sir. So we would go to the second topic, and this would be none other than Dr. Baldev Prajapati, a very well-known pediatrician, HOD and professor from GCS Medical College, Hospital and Research Center, Ahmedabad. And he has held several posts in IAP. To mention the few, he's been the executive board member, IAP committee member on immunization, and ID chapter chairperson. And he has contributed a lot of chapters in the IAP modules. And I have listened to him on many IAP platforms, and he's an excellent teacher. Sir, over to you, Baldev Prajapati, sir, for the topic of power of observation. Over to you, sir.
Welcome, sir. Welcome, Prajapati, sir. Madam, in addition, no PG clinic will be done without Prajapati, sir. And the amount of teaching he has done is hats off to you, sir. We are happy. We are really honored to have you today with us, sir. Over to you, sir.
Myself and Dr. Srinivasan, sir, always support what Dr. Singarwelu is saying. He's a great person, Dr. Prajapati, sir.
Good evening, friends. Thank you very much, madam, for your kind words, and Dr. Singarwelu for adding few of them. I will talk on this little bit, I will say different title, power of observation in the clinical practice. I am sharing my PPT. Is it seen?
Yes, sir. You can go to the, yes, sir, but go to the slideshow, sir.
Yeah. Sorry, let me start again. There is some.
Make it full screen, sir.
Yeah. Is it okay?
Yes, sir. Yes, sir.
Yeah. Am I audible?
Yes, sir.
Fine. Thank you. This power of observation, which is somehow underutilized, and you are not given the much value also, which I'm sure that you will agree with my some illustrations. We should know what we mean by the observation. Observation is not beyond mere seeing, what we are able to see. But observation is vision with the critical thinking. Observation means ability to notice even the small and significant details. Observation can be extended even to the listening to sounds, not just hearing. And the time spent for observation is, I will say, worth. With repeated practices, it does not take much time, and I think it's not time consuming once it becomes our habit. Sometimes we may be surprised to find what all can be assessed before touching the patient. And that is the power of observation. And as I said, somehow this clinical skill is underutilized and even undervalued. And therefore, Sherlock Holmes long back said that you see, but you do not observe. And I think it's true in our clinical medicine. What to observe? Look at the patient. What is the appearance? Is it sick looking or well looking? Posture and attitude of the patient. Any dysmorphism? What is the nutrition of the patient? What is perfusion? Breathing? Even nature of cry? What is the mental status? Some even the abnormal movements and gait, which you can just observe. And I'm sure that these are the simple points, but helps a lot, I will say, coming to the conclusion. Please don't forget some red flags. All of us know that ill-looking, sick-looking child, I may not have the answer, but I understand the gravity of problem. We know that altered sensorium, either the drowsiness or irritability, both are, I will say, extreme, but at the same time, very important. Lethargic child may be due to the poor perfusion in a case of dengue. Signs of increased work of breathing, particularly the tachypnea, chest indrawing sounds, even abnormal posture in the form of the dystonia, decorticate, decerebrate, even opistotomus. I'm sure that just simple observation gives you the clue. Bleeding skin lesions, petechial purpurate, maybe the sepsis, dengue, or even the meningococcusemia. And just looking at the throat, if I get the membrane, in a sick, toxic child, it's diphtheria. We know that anxious look, hydrophobia, and aerophobia does not require for the diagnosis of rabies further any investigation. Friends, this, I will say, red flags, a clinician, mature clinician should not miss it. What we gather from the appearance or look, which already I talked regarding altered sensorium, maybe due to hypoxia, poor perfusion, hypoglycemia, maybe the dyselectrolytemia like hyponatremia or hypernatremia, encephalopathy, or even the encephalitis. So many things. Extreme irritability of seizures in a chubby child with diarrhea. I will first predict the hypernatremia. Screaming an infant following diarrhea, few days back, maybe the intussusception. Generalized edema with sick-looking child in monsoon, I will say first consider the dengue fever. But generalized edema in a happy child, maybe the nephrotic syndrome. But such a nephrotic child, when become the sick, first I will think for the infection. And if it complains of nephrotic syndrome, on steroids with sick looking and abdominal pain, first point will come to my mind is the peritonitis. Acute onset purpura, well looking child, most common ITP, but sick looking with fever, maybe the leukemia. Friends, what I want to share with you, just a simple observation, noting the point, helps a lot, I will say, coming to the conclusion, and most of the times you are right. If I share this child with dysmorphic facial features considered by many people, but when I looked at this is a dysmorphism, which even the macrocephaly, blue sclera is obvious. You can see the prominent ears. Immediately on examination, hypotonia, but DTR were brisk and high concentration of glutaric acid in urine and blood. Simply we confirm the glutaric aciduria. Friends, what I want to share with you, just your observation, and if you are knowing, I will say it clinches the diagnosis. Even signs of increased work of breathing, tachypnea, indrawing, that to subcostal, intercostal, suprasternal, and every indrawing will give me the idea that where is the problem. Abnormal stride, you know the stridor, upper airway obstruction, wheezing, maybe the intrathoracic, and grunt is a serious sound, maybe due to some respiratory failure or going in a hyaline membrane disease or severe pneumonia in the older children. Flaring of Helenizi, head bobbing, abnormal breathing is a very characteristic. We know that audible respiratory sounds and site of origin already we can discuss. Nasal snuffle, that is nostril and maybe even the common cold simple or maybe the syphilis. Snoring in the oronasopharyngeal airway, most commonly adenoids. Stridor, extrathoracic airway obstruction, laryngitis, vascularing, some mass pressing over even the airway. Wheezing, intrathoracic airways, maybe the bronchiolitis or bronchial asthma. And grunt, as already I said, maybe the hyaline membrane disease or severe pneumonia. Simply, I'm talking to my students that if you put on the paper regarding these sounds and even these tachypnea, retraction, stridor, wheeze, and grunt, and that will give the exact idea that where is the pathology, that will give the exact anatomy. Abnormal breathing, all of us know, the rapid, deep, labored breathing, maybe the small breathing, diabetic ketoacidosis, simply from observation, you can say and you can confirm. Rapid shallow breathing, maybe in a case of pleurisy. Tachypnea without indrawing and sounds, maybe the metabolic acidosis. That may be the renal tubular acidosis or inborn error of metabolism, or even diabetic ketoacidosis. Chin-Stokes breathing, apneistic breathing, we know that indicates a central problem. Even it is said that experienced pediatrician, from the cry, you can suspect something. We know that the shrill cry, particularly in the younger babies or the newborns, high-pitched cry, that is the raised ICP, maybe the meningitis. Screaming in a case of intussusception. Continuous irritable cry, all of us know marasmus, but not crying, or intermittent weak cry, because does not want to spend the energy in a case of kwashiorkor. Hoarse cry, all of us know, maybe the hypothyroidism, acute laryngobronchitis, or acutely presenting as a Krupp syndrome. Cat cry, all of us know, rare, but maybe the cry-du-chat syndrome. An infant with the difficulty in feeding presented, and my resident said that there is the multiple interruptions. What we say suck-rest cycle, prolonged period of breathing more than 30 minutes, excessive perspiration over the forehead. I'm sure this, I will say as a clinician, suspect that this is the congestive cardiac failure. These observations are sufficient. Later on, I will get the cause for this is here. You know, in a case of jaundice, always I share with my friends, look at the eyes, urine and stool. That will give the diagnosis, likely where is the problem. Yellow eyes, yellow urine, stool is normal. It's a hepatocyte disorder, most commonly hepatitis. Light yellow eyes, urine is normal, stool is normal, but pallor is significant, then it is a hemolytic anemia. Dark yellow eyes, dark yellow urine, but the clay or white colored stool, all of us know, and suppose if you get the scratch marks, it's an obstructive jaundice. Later on you can find. What, friends, I want to share with you, just to gather the very simple information that will give the idea that what you should consider further. Severe iron deficiency anemia not responding to iron. I would like to share one patient presented with us in this way, but I think somehow it was not observed. When we saw that this is a hyperpigmented knuckles, and even the CBC, which was asked by the previous pediatrician, already MCP was high. It was not observed, and it turned out to be the megaloblastic anemia. Not, I will say, uncommon, but I wanted to share to draw attention. 8 years old male presented from I will say, Rajasthan with a chronic diarrhea, loss of appetite, severe anemia, and hypocalcemia. We didn't have the exact cause at the time of presentation. But in a round, when I observed that with severe anemia, I'm sure you're able to appreciate that the nails are quite pale, but clubbing. I think it's contradicting. In iron deficiency anemia, I'm expecting either the plateluria or chylomicronemia. Here it is clubbing. And that was an important clinical, I will say, clue, which has suspected the anemia with the clubbing, then and not responding to iron. We further went for the workup, serological test and endoscopy, and confirmed the celiac disease. Friends, what I want to share with you, anemia with clubbing together, if you get it, consider celiac disease, Crohn's disease, ulcerative colitis, maybe sometimes in a case of PO, bacterial endocarditis, or even the unexplainable CCF, maybe the AV fistula. This is very important. Nowadays, fortunately, we don't get much such patient, but this is an old which I got it. 8 years old boy, difficulty in chewing and swallowing. I think my senior friends very easily they can make out that was Rhizus sardonicus, and observation tetanus was quite obvious. Friends, what I want to share with you, that distension of abdomen, always we say distension. I think it's not sufficient. Go, what type of distension? This is one figure you can see what type of distension, that observe that it is the huge splenohepatomegaly. Another patient also the distension of abdomen, but you can see the flanks are full and even tense. And this is the classical ascites. But recently we had one patient, again distension, but you can say central distension. And that we discuss the mesenterics. Even the sonography, the CT scan was reported as ascites. But we said that this is not the ascites. And I remember we suspected mesenterics, but on operation, we got the lymphangiectasis. So this is the, I will say, beauty of power of observation. You can say that what is the likely reason for this distension. This was an 18 months female hospitalized for pneumonia. I remember long back when we used to use this femoral puncture for collection of blood during our residency. And meanwhile, with one of my friends, when he was collecting the blood, that was later on child developed the fracture of the shaft of the humerus. And then that was referred to the orthopedic surgeon. He applied the plaster for this immobilization. But my teacher, I remember late, Dr. Madam Desai asked that why this is not the traumatic fracture, this is a pathological fracture. She asked to look at the sclera, and that was the blue sclera, and case of the osteoid imperfecta we got later on confirmed from the skeletal. What, friends, I want to share, just looking at the pathological fracture and blue sclera, master observation, that power of observation, which clinches the diagnosis if you are aware of it. I remember this girl was referred to us for the hypothyroidism, but at the same time, not simple hypothyroidism. She had acanthosis nigricans. And this later on for the workup, all of us know it's a sign of polycystic ovarian disease. This patient was kept for the spot diagnosis in MD examination. Everybody said it's a facial palsy. But friends, I want your attention. You can see that nasolabial folds are normal on both the sides. And then I said it is a congenital absence of depression angular resolution. Friends, again, what I want your attention, that observation, just observation. No, I will say our investigation is going to answer this question. Similarly, I remember this newborn in our own department, after 2 or 3 days of the delivery, just discharged this baby, and later on brought to the OPD, and mother said it was not at the time of discharge. What went wrong? That was a facial palsy. But you know, every time when the resident has taken the postnatal round, baby was sleeping. and therefore not noticed. And therefore, what the neonatologists are always conveying to us, newborn should be examined in both the phases, sleeping and crying. Always examining the crying baby. That will give, and this I will say, not so common, but yes, possibilities that you may miss even the facial palsy. I remember in one of my rounds, older child and development, my resident said it is normal. I showed you, we can see the callosity of the knees. And this callosity, that means child is walking the knees, and later on the further workup, turn out to be cerebral palsy. Friends, just simple observation that why this callosity in the older child, why the child is walking on the knees. And that's, I will say, point which will lead you for further, and mild cerebral palsy, which may be easily missed by the people. Here it was a 2-year-old boy, fever and hypersplenomegaly and lymphadenopathy. I remember this patient was referred to us. There was a referral from the skin OPD with this at the scalp lesions. And all of us know that there is a seborrheic dermatitis. Seborrheic dermatitis in a child with fever, hypersplenomegaly, lymphadenopathy. We went for the further workup. It confirmed the Langerhans cell histiocytosis. All of us know that this is the very characteristic of even the histiocytosis of seborrheic dermatitis, which is going to be interpreted in this scenario. Here it was a 4 years male, skin lesions for the buttock and lower limbs, loss of the scalp hairs, irritability, and edema were treated with multiple, I will say, antibiotic drugs and so many things. This is very classical picture over the scalp and even the perineal region and even over the lower limbs. And that was the acrodermatitis enteropathica. You can see even after the treatment how this patient is improving. Just I will say observation. That, of course, it should be in your mind. So I remember that the child was referred for these rickets, and multiple times the treatment was given, but presented with a respiration at more than 80. And that was the acidosis. Now there is no chest drawing or anything. And we can say that this is not simple nutritional rickets and turn out to be the renal tubular acidosis. Even if you see that vitamin D resistant rickets type 2, because the loss of the scalp hairs is a very characteristic of even type 2, which does not require probably further investigations. Of course, for the further management you can do, but I am sure that you are damn sure for the diagnosis. This was the 11-year-old female. I remember from Mehsana is a district nurse from Ahmedabad, referred for deteriorating school performance and changing the behavior and lack of attitude, irritability, no fever, no seizures, and frequent falls even, unsteady gait, and referred for opinion observation. I remember that while I was taking the history, child was in front of me, and there was child, her head suddenly struck on the table with a violent, sudden, jerky movement. I will say, and then I observed that the multiple injury marks were over the face, and that was very obvious that this is the SSP. This is the myoclonic jerk. Friends, what I want to share with you, if you are knowing, just observation. Just, I am sure that if you clinch the point, you can confirm the diagnosis. This was a 3 years male, referred for persistent, even the enzymatic reaction for 8 months. We didn't have the answer. Liver was 2 centimeters soft and spleen was not palpable. I remember I didn't have any answer for even the hepatitis, inborn metabolism, Wilson, everything we did. Sonography was normal. But just I observed once that while getting up from the examination table, child was rolling over and taking the support. This my observation on the 4th visit. I suspected that this is the goer sign. It is the incomplete for 3 years, which became the complete at 5 years. But this is the thing that, and later on CPK was sky high, LDH, EMG, everybody confirmed that this is the DMD, solution variety of pseudomuscular dystrophy. Friends, what I want to convey, I got the point just from the observation that how the child was getting up, rolling over and taking the support. That was the observation which I didn't have the answer for the raised SGPT and SGOT, but later on I thought that this is a possible goer sign. And Menke, if you remember the pediatric neurology book, it had mentioned that the incomplete goers will be seen at 2 to 3 years, which will be completed classically present at the age of 5 years and beyond that. This was a 2-year child present with a high-grade fever of 20 days duration. This was the observation that rapid, uncontrolled, irregular eye movements in both horizontal and vertical directions. Friends, I interpreted the obscureness, measured the blood pressure, and that was the hypertension. And diagnosis was obvious of neuroblastoma. Just from the obsclonic movement of the eyeballs, everything was later on investigated and confirmed the neuroblastoma. Friends, I am sure that be the master clinician, observe even the small points, note it down. You are not sure when it is going to be the important clue for the diagnosis. I will say that's the story which I want to share with you. Another child, 15 months male with diarrhea and the weight loss. This was the picture. This is a scalp, the swellings. We didn't have the answer. We went for again the biopsy, turned out to be the neuroblastoma. One more patient. I remember that history of fall from mother's lap while giving the breastfeeding. I will say I think last year probably this patient was there in our unit. My resident told that this is the picture of the patient following fall from the. I said fall is not the responsible for this picture. We thought of the scurvy, leukemia, or the neuroblastoma. And further workup again, you can see the a very classical. I remember I asked my residents to open the Nelson. Nelson has similar picture of the raccoon eyes, and that my resident Asha Chaudhary, I remember she showed me the mass in the abdomen turned out to be the neuroblastoma. Friend, just observation, nothing else. Later on, of course, we could confirm the diagnosis with necessary investigations. This was a 3-year-old child operated for ASD and presented with this type of the paradoxical, I will say, movement of chest, that is the paralysis of the left dome of the diaphragm, and that was injury to the left phrenic nerve following the operation for the ASD. Another baby was having the vaginal difficult delivery, having the same respiratory problem, and that observation made the right dome of the diaphragm. I remember this, my resident discussed that this is the increased work of breathing, respiratory distress, but that was a paradoxical movement. And again, it was, I will say, injury during the brachial plexus and phrenic nerve during the difficult labor, and this was resulted. This was an 18-month child with the fever. We didn't have any perineal disclamation. In my signs and symptom book, I mentioned in this picture, classically turned out to be the Kawasaki disease. Yes. You know, there are very important, I will say, clue that I will say pathognomic some of the signs, which as a clinician will have to clinch it. I remember this patient with the multiple skin rashes and some gangrenous changes at the ear and even the fingers. And we searched for and got this eschar. Later on, we confirmed that yes, it's a rickettsial disease. It was not the Pseudomonas, which my residents were treating as the Pseudomonas septicemia. This was the 8-month child, high-grade fever, skin rashes and the lymph nodes. And again, I observed that the reactivation of the BCG with a very high count and thrombocytosis. I'm sure that now with this picture, you should not have any doubt, and that turned out to be the Kawasaki disease. Friends, just a simple, my one point, my observation contributed a lot, which probably ECG or even the echo or any other investigation, radio imaging may not be able to help me. This was a 1-year child present with high-grade fever, cough, coryza, rhinitis, conjunctivitis. Thoughts even showed the lesions of buccal, as this is very classical nowadays, not seen, but the coplic spot in the measles. I remember the patient of pancytopenia presented, and just I observed the thumb. You know, and therefore, many times I'm asking any patient of anemia or pancytopenia, what you will look. This is the tripharyngeal thumb with the deformity. And later on, you know, the chapter will open. It confirmed even the multiple anomalies, even renal anomalies, and the Fanconi's anemia. I remember this patient was high-grade fever, toxic lobe, which I was talking, even the bull neck, and you can see the membrane. I think each patient, don't wait for the confirmation. Start anti-diphtheria serum so that we can save the patient. It's a diphtheria. Sudden excessive crying of 1 hour. Only 1 hour, no fever, no obvious reason. And this was the picture. You can see the left side testicular swelling, and this is what the torsion of left testis. And friends, we know that within 6 hours, if it is not managed appropriately, there will be loss of the testis. And that's the role of the clinician, just observation. This was the 14 months female, keeping the neck flax, high-grade fever and toxic look and irritable, and drilling a lot. I remember I was entering my consulting room. In the waiting room, I saw this patient. I told the sister to take it immediately. We went for the further workup and turned out to be the retropharyngeal abscess. Classically, less than, I would say, 3 to 5 years old child, presents with high-grade fever and toxic look and irritability, and not able to swallow, and therefore drooling, not able to look at the ceiling because the neck is always keeping the flax. And that is a very classical picture of the retropharyngeal abscess. I'm sure that if you are knowing in life, even you saved 2 or 3 patients, I'm sure that that is a success story for any clinician in the life. And that I remember that aspirated my friends and saved the child. I remember this was my resident showed that this girl is having these type of movements of the eyebrows. And what's the problem? In the history, we got that the 7 years, 20 kg weight, vomiting 8 to 10 times, following consumption of some pani puri, treated by the family doctor with the dome stall drops rather than the dome stall suspension. Suspension contains 1 milligram per ml, drops contain 10 milligram per ml. Prescribed 5 ml TDS, that is the 150 milligram per day, and that turned out to be 450 milligram, which is quite high. And that was a very classical. I explained the whole story to my residents, and this is the oculogyric crisis due to the, I will say, this type of the drug induced. That also we should keep in mind. Friends, these were some illustrations which I wanted to share with you to emphasize that what is the really power of the observation as a clinician or clinical medicine. Observation is not just merely seeing. All of us are able to see, but all of us are not able to observe. Observe means to see with the critical thinking. We need to train our minds to observe. Please, I'm sure that we should have some question why it happens so. Repeated practice of observation does not take much time. Then it becomes our habit. And good observation may detect an important clue leading to diagnosis without even touching the patient, without help of any investigation. And friend, that is the power of observation. Somehow, I'm really sorry to mention that it is underutilized, and somehow after even the observation, it is undervalued in the practice, which should not happen. Thank you very much. Thanks a lot again. Thank you very much to all the organizers for inviting me and giving this opportunity. Thanks a lot.
Brilliant cases.
Very much, sir. We all agree that this underutilized, undervalued power of observation has been so well highlighted, which is very, very essential for a clinician to make accurate diagnosis. You brought it with excellent illustrations and case scenarios, sir. Thank you very much. And I saw the popping answers by one Dr. Haripriya, who was almost answering almost most of your clues.
Oh, fantastic.
Yes, that was a very nice thing. So thank you very much, sir, TNPSC, Tamil Nadu State Chapter, for this very nice lecture, sir. Thank you, sir.
Thank
Over
you,
to Dr. Jalil to take over the next 2 sessions.
Thank you, Nandini. Sir, thank you, Prajapati sir and Maheshwari sir, for your excellent presentation. We are lucky to hear your lectures. And as Dr. Nandini mentioned, there is a prompt, rapid-fire response for your presentation. One Dr. Haripriya. So that shows our listeners are very active and they are eagerly watching the topics. And now we move on to our...
Dr. Jalil, my small request.
Yes, sir.
Can you send me the contact number of that postgraduate who answered
Sure.
all? Because always I love to talk to the students.
She is to be given a certificate of merit in the Kongu Pedicon.
Her name is Haripriya. I will send you, sir.
Thank you.
Thank you so much, Prajapati sir.
Thank you.
Now we move on to the next topics. At the outset, I thank the IAP TNSC, our president, Dr. Rajendran, our past vice president, Dr. Singaravelu sir, for having organized this curtain raising program. My special thanks to our Kongu Pedicon 2.0 version, having this program for the PG student. I can acknowledge the presence of Professor Srinivasan, who is also our mentor, and Devendra Serin, all the other faculties. And it is my pleasure to introduce my own good friend and a very humble friend, who is none other than Dr. Paramanand, who is our 2024 Joint Secretary Admin when I was a EB member. He is a very humble and very soft-spoken. And he is currently the Pediatric and Neonatal Intensive Care Unit at the Jupiter Hospital, Thane. He is a EB member and joint secretary of the IAP. He held various postings in the West Zone. And thank you very much, sir. And now I request you to proceed for your talk on case-based scenario in pediatric emergency. Over to Dr. Paramanand, sir.
Good evening, sir. Thanks for the nice word, Jalil, sir. And I thank Tamil Nadu State for giving us an opportunity. Good evening, Shingarvelu, sir, for inviting me for this wonderful session for emergency and critical care. What I've selected few cases which are usually seen in as a routine, but there are certain untoward complications which can occur, and we should be alert while treating these patients. So I will share my screen with this.
You can put it on the full screen. So, yeah, sir. Yeah, sir. Perfect.
Okay. So the first case which I will just evaluate the tough typhoid, given the name also. This was a kid of 10-year-old child, previously well, was brought to us with history of fever for 5 days of duration, high grade, intermittent, associated with it with the chills. History of viral illness, upper respiratory tract infection around 15 days back. There is this similar history of having fever and diagnosed of enteric fever in a mother. She was hospitalized for the same and treated. Blood culture and investigation were sent, and the child was treated on OPD basis. When he presented to us, he was referred to for thrombocytopenia with platelet count of 10,000. The child was admitted and was evaluated for further. On examination, he was conscious, alert, oriented, febrile, and tachycardic. Then there are multiple PTK with bilateral. The examination, they had splenomegaly in the and
That's kindly unmute. Go ahead, sir.
Investigation was sent initially from outside. Hemoglobin was 10 grams. WBC counts was 8,410. Platelet was 10,000. At Jupiter, it was the hemoglobin was 9.2. Local leukocyte count was 12,590, and total platelet count was just 4,000. The rest of the investigation were SGOT, SGPT 80 and 62, mildly elevated. Bilirubin was 1.45. So the day one, we thought of with the etiological workup, let's see, luto, malaria, there coexisting illness like dengue, which was normal. PS was done, which was very occasional large platelets. RBCs was normal. There was hypochromism, microcytosis, and as well as no evidence of hemolysis was seen on the smear. Was treated, was given, platelet transfusion was given. But considering considering the thrombocytopenia, we thought of whether it's and was given IVIG, thinking of immune cause, and was started on ceftriaxone and azithromycin, as we have seen the epidemic of the enteric fever with the ceftriaxone resistance right now. So provisional diagnosis was made of enteric fever with thrombocytopenia. And we got a culture which was suggestive of a ceftriaxone resistant, and he was on azithromycin. The other investigations were sent, but child continued to have a fever. Was the USG was done, which was showing normal ecotexture with increased renal cortical echogenicity, with early loss of CMD, and spleen was there was a splenomegaly. Urine was showing 3 cells and 50 red blood cells and little proteinuria. We all know that in the first week of sight there is a bacteremia. Second week there is a widespread reticuloendothelial involvement, foci and the necrosis of liver. In stage 3 or the third week of illness in the enteric, if not treated properly, can lead to ulceration of Peyer's patches, intestinal bleeding, or intestinal ulceration. And chronic is a 4th stage. So in this, our patient, a child with was still bacteremic phase, was ongoing fever, was treated with azithromycin and added meropenem was added, and gastric protection measures were taken. So known hematological complications we all know in typhoid. Anemia may be because of GI bleed. Whereas immune cytopenia can occur, most probably thrombocytopenia. They can go into DIC. There can be a bone marrow suppression manifesting as a pancytopenia. So on the further course in the hospital, so we had always had a thrombocytopenia which was persistent, and hemoglobin was started dropping. And the platelet after giving transfusion also there was hardly any rise, and there was fever was persistent for more than 2 weeks. Antibodies were already on meropenem and azithromycin for the enteric dosage. So the challenges in this, the understanding the pathogenesis, what is the cause can be of this thrombocytopenia. So we all know the thrombocytopenia can be because of disruption or reduced production, or there can be an consumption. Anemia can be there, but there was no blood loss, no GI bleed, no obvious loss of blood which was causing the anemia. And there was one finding which was significant. It was leukocytosis, which was probably leukemoid reaction was thought of. Initially, we thought of HLH, 2 cell line down, but usually they have leukopenia. So it was unlikely the leukocytosis, that's why HLH was thought of, but it is still because of leukocytosis, we said we may not be there. So further investigation which was done, which date for 13, hemoglobin has dropped to 5.5, and the platelet was still further dropping, but it was 8,000. And it was refractory, which was giving the SDP as well as from IVIG, there was no response to the rise in platelet and the fever was persistent. So what it can be, so we had whether it's a destruction so the hemoglobin from day 5 to day 14, it has a drop in hemoglobin, rise in LDH, serum creatinine was always in the normal range. Hemoglobin was 9.2 to 5.1. Platelet was persistently low, persistently resistant thrombocytopenia, not responding to IVIG. And peripheral smear, initially there was no signs of any hemolysis, and later on they were showing 3 to 4 RBCs which were destructed, and disease the DCT, ICT done twice were negative. So it was not the immune phenomena which is causing this problem, but it is the RBC which is getting destroyed. And where? So there's a child is clinically better, but fever spikes was spacing out. We did the CT to look for any other complication, but it was only suggested mild splenomegaly and no other significant lymphadenopathy. So we thought of persistent anemia, thrombocytopenia, which histiocytes on smear, which was the finding which was later on, which came up with the elevated LDH. But urine output was always normal, and there was no uremia, creatinine was normal, no hypertension. And we came to the diagnosis of microangiopathic hemolytic anemia without renal involvement, which was one of the rare situations which we were thinking of. So whether it's an HUS or hemolytic uremic syndrome, but there was no oliguria and there was no hypertension, creatinine was normal, and only there was suggestion of the microangiopathy because of anemia and thrombocytopenia. If we look at the literature, there is showing with typhoid toxin and cigatoxin, a typhoid can lead to this type of problem. In toxin involved, no direct cigatoxin. Cigatoxin can cause this problem. Immune-mediated systemic inflammation and direct invasion. Time of onset usually occurs during an acute phase, and usually with the cigatoxin, it occurs at least 5 to 10 days after the illness. The diagnosis, the blood and stool culture suggestive of Salmonella typhi, and here the cigatoxin can be done. In our patient, the blood was suggestive of the Salmonella typhi. So we thought of the typhoid-induced HOS. So pathogen of how it affects the Salmonella typhi leads to endotoxin release, which damages the glomerular microangiopathy, leads to renal intravascular coagulation due to red cell fragmentation. And this intravascular coagulation lead to not always widely disseminated type, or called as disseminated intravascular coagulation, but it is localized to the glomeruli. And and there is a specific finding of leukocytosis may points to our HOS, which is not there like an HLH. So if you have the leukocytosis with intravascular coagulation findings or hemoglobin which is dropping or thrombocytopenia, you may think of localized HOS which can occur in a patient with typhoid. So we send the other factors, which are factor age, Adam tests, and complement levels were sent, which came normal. While awaiting the result, We were counseled the family can go ahead with plasmapheresis, and the other positive factors were any which the immune was negative. So we initiated the plasma transfusion. We gave the PRBC transfusion, platelet transfusion, and taken for the single volume plasma exchange. A plasma was planned, and the patient went ahead with the plasmapheresis. When we started the plasmapheresis after giving platelet, initially the response first 3 cycles, 4 cycles was not that significant, but later on we showed persistently the platelets started improving. And see that hemoglobin, which was 5.5, 7, 7.7, the hemoglobin started maintaining well, and the platelets started rising, and WBC the count started coming down to normal. They required around 5 cycles of plasmapheresis to get the platelet count to be normal. We continued alternate day plasmapheresis and were monitoring the hemoglobin drop, the platelet function, which is platelet count, which is normal, LDH, and the other the signs of hemolysis and the schistocytes on the smear. Gradually, the schistocyte disappeared. This is the smear which was showing fragmented RBCs before plasmapheresis exchange, and this is after plasma exchange. There was hardly any the schistocyte. So it was unusual case of the typhoid-induced HUS. The child eventually got discharged after the 8 cycles of plasmapheresis. On OPD follow-up, the child was clinically well. Hemoglobin last was 11.5. Patient improved, platelet improved to 3.5. And it doesn't require any other medications later on. So we looked into the literature. There were certain presentations. The series present are shown in the literature as early as, and it was suggestive of a hemolytic uremic syndrome, the associated with Salmonella typhi. The other, so in this lecture reason, we labeled it as a tough typhoid to handle. We had prolonged fever, Salmonella, which was resistant to ceftriaxone, evolving kinetics of thrombocytopenia. It complicated with because of HUS and required plasmapheresis. Friends, this can be prevented if we give typhoid vaccine and prevent the severe illness. And rising antimicrobial resistance, difficult to treat such situations. Can cause public health impact. WHO recommends typhoid conjugate vaccine as early as 6 months of age to provide immunity. I recommend all of you to use the typhoid vaccine, and so can in future we may avoid such complicated situation can occur. So the typhoid can do more damage than expected. Timely intervention, PLEX, when indicated, and other supportive care can help in few of the situation. Typhoid vaccine is the first line of defense against the typhoid, and it's rare but serious complication. So I humble request to all of you to use the typhoid vaccine and prevent. We'll go to the next case. This is an interesting 5-year-old female. We came with a cough, the cold for 1 day, runny nose, not associated with sneezing. Cough for since 1 day, dry, intermittent, not associated with sleep disturbance. Fever for 1 day, high grade, went to 107 degree Fahrenheit, not associated with rigors, rashes, or reduced and was not reducing by antibiotics, and interfebrile the people was active that day. He developed a paroxysmal event at home associated with upperling of eyes, with frothing from the mouth, with loosening of whole body, not responding to verbal commands, which was not associated with tonic-clonic movements, urine and stool incontinence lasting for 5 minutes, followed by post-ictal drowsiness. So he had a cough cold, like a flu-like illness, followed by the paroxysmal event. So taken to the outside hospital for the above complaints, had a second seizure there and similar to the first, and aborted by giving midazolam nasal spray there. And then they was started on oxygen, antipyretic, and referred to us for further management. In Jupiter Hospital casualty, the child was drowsy, preferring to sleep. The ictal period, the patient was not normal. So it was not like a febrile convulsion. So it may be labeled as a status epilepticus, as in between 2 febrile seizures in this, and the baby is not coming back to normal. So it is not febrile seizures. We had to think something else which has happened, even though the child was in the age group of febrile convulsion. How we look at the patient drowsy, preferring to sleep in interfebrile period, not responding to verbal commands. GCS was 11/15. Peripheral pulses were well felt. Blood pressure was lower side of normal in that age group. We loaded with Levipil, started on oxygen, given the fluids at that time. The blood gas was showing like alkalosis, with CO2 was normal, mildly lactate elevated, but not much of abnormality. So we transferred the patient to ICU with the heart rate, which was 133 per minute. The vitals were somehow maintaining with minimal support with an oxygen. Peripheral pulses were feeble, so started on the supportive medications for noradrenaline. The baby on CNS examination was not responding. Bilateral pupils were normal. The pupils were 3, reactive to light. Tone was normal. Power was 4/5. Deep tendon reflexes were 1+. Plantars were flexor. So there was hardly anything, but the apart from drowsiness, there was no other clinical evidence of any raised ICP. So with the outside investigation was not that much of conclusive. Hemoglobin was 10 grams. WBC was 11,400. Platelets were 2 lakhs. And the CRP was 18.7. Mild elevation of SGOT and SGPT. But creatinine was high. So he had some renal damage, like an injury which was there. Ionized calcium was normal. Sugars were normal. Malaria antigen was negative. No other metabolic factor which was causing this fever was present in this child. So in view of the altered sensorium, we did the MRI, which looks like to be the previous. Bilateral thalami, which were was getting affected in this child, and it was like an acute necrotizing encephalitis. It is a rapidly let's go back. So it is acute necrotizing encephalopathy with the child. It's a rare neurological emergency which can happen with the influenza-like illness. So this suggests you have a classically which is seen, the affected areas are thalamus. So it is a rapidly progressive brain damage. It's a rare but aggressive condition primarily affecting the previously healthy kids. It triggered by viral infections, and most common form of viral infection leading to severe brain complications is characterized by inflammation, swelling, and distinctive lesions, especially in the thalami. Usually the typical presentation is a benign symptoms like fever, respiratory issues, or gastrointestinal issues, but there's a rapid neurological decline. Within days, symptoms can escalate to seizures, altered sensorium, and persistent vomiting, indicating the severe brain involvement. So as I was repeatedly saying, it's when the baby is having convulsion with fever, and the sensorium is not coming to normal, and with the flu-like illness, it may not be febrile convulsion, and it can turn out to be the acute necrotizing the encephalitis. So the MRI findings, as I said, the bilateral symmetrical thalamic lesions often shown as a trilaminar sign. The blood tests usually are normal, which elevated enzymes which were there in our patients, CSF usually is normal. Genetic testing can be done. There is a mutation in RAMP2 gene which has been associated with this type of condition. The underlying cause and pathogen, it's usually a viral trigger, most probably the influenza A and B, which are the most common causes of this. It's an immune-mediated injury. It's a cytokine storm which can occur, and there is an increase in the IL-6 and which can cause severe brain damage. Usually they have genetic susceptibility. So what is the treatment strategy or how it differs? It's an immune modulation therapy, IVIG and steroids are the vital role in the initial therapy of this type of problem. Targeted antiviral therapy you may give. Intensive care support is required, and the management of the seizure control. Apart from this, so what in our patient, we involved the neurologist, we gave 3% normal saline to decrease the head intracranial tension. The report was H3N2, which was positive. It was influenza. So influenza, it's as we can sometimes consider as a minor illness, like a flu-like illness, but they can cause such type of neurological emergency. The IL-6 were saying it's 106, which was pretty high. And the drug of choice, which we want to mention, it's here the tocilizumab, which can be given in such type of situation. It's an injury. It's not a viremia which is causing a problem. It's not an encephalitis. It's an inflammatory or a cytokine storm which is causing the neurological injury. And here the treatment differs. It's an immune suppression, aggressive immune suppression, which is required. Like medicines like the IL-6 blocker, which can be used along with methylprednisolone and IVIG. So how did tocilizumab? It helps in humanize monoclonal antibody, originally approved for autoimmune diseases, and intervention, if you use within 24 to 32 hours of neurological deterioration, it can lead to significantly better outcomes. We have treated in the past, we have seen the sequelae which was bad, but mind you, now if you use the drug within 32 hours, you have seen a good neurological outcome. And that is the only change which can occur apart from the flu causing an ache, which can be there. So it blocks the and calms down the inflammatory storm. That is the way the tocilizumab helps. And definitely there are case reports which are suggestive of the nephrotic encephalopathy caused by the influenza viruses, and which has been treated with the tocilizumab, is showing good results. So conclude, tocilizumab is a game changer in pediatric neck, and tocilizumab represent a critical advancement in managing acute necrotic encephalitis, which should be used within 24 to 32 hours. That is the only thing which I wanted to emphasize. If the patient has a fever, convulsions not improving, and it is not in between the fever, multiple convulsion. If the sensorium is normal, then it's a febrile convulsion. If it is not normal, deteriorating, get an urgent MRI, diagnose this condition, and because it is important to give this drug as early as possible to get a good neurological outcome. So there are if you don't treat, there are more than 70 to 80% have a neurological sequelae. So it's very important to give this drug as early as possible. Again, we all are pediatricians, and I request you all get vaccinated and protect yourself, and you can prevent such type of the major problems with the mild disease which can be thought of. They can sometimes this can cause a severe neurological injury. Sir, if I can have time, then I can have a third case, or
you have another 5 minutes, sir.
5 minutes, sir.
I'll just try to.
Yes, sir.
The dengue, which we all usually treat. So I will just brush up the importance of, again, an immunological issues which will come up in the day-to-day treating, like a dengue, which we all. Is a 12-year-old female child presented with nausea, reduced oral intake, reduced urine output, and generalized weakness. Was investigated and was having the signs of the warning signs were present, and was that on examination, she had the blood pressures were the normal, but there was a tachypnea, liver was palpable, and it was like an suspected to a dengue with compensated shock, or dengue with warning signs. Here, then the questions comes to our mind: how to manage, what type of fluid, role of colloid, blood products, role of any other investigation, other modalities of treatment usually come. So all we give fluids, we give, and most of the 99 or 95% of the patients improve with only a fluid management. Again, there are few of them we have some untoward or the problem which can occur. In this case, the patient had the platelet count was 14,000 to 1,40,000 to start with. But mind you, here the CRP on day one has we usually don't give importance to it. But here is certain importance in a dengue. If you have a positive, there can be an inflammatory response, and not only the viral etiology which can be there. Here, the later on, the platelets started dropping, but see the liver enzymes went on increasing, and his NS1 was positive. And later on, patient developed an altered sensorium within 8 hours of admission and had cerebral edema. So in a course, we was dengue shock syndrome, which was thought of, was treated on that. It is important to understand the pathophysiology of dengue, and it helps in management better. We all know the dengue virus usually, with the severe dengue, there will be a defervescence stage. There's a peak of viremia suggesting host immune response. But there can be that severe clinical dengue can occur due to antibody dependent enhancement, or there is an antibody dependent cellular toxicity, or cytokine storm, or aberrant activation of the complement system. Most of the dengue, they have 3 to 4 days of fever, then fever subside, they find 1 or 2 days of decreased appetite, and they usually recover. Few of these patients will have sudden onset of fever, and the liver enzymes are deranged, and then the coagulopathy, which is severe, start thinking of this is inflammatory reaction. It can be a cytokine storm, and send serum ferritin. Here we have sent the serum ferritin. It was 1,65,000. And this with the challenges was dengue shock syndrome with multi-organ involvement, hyperferritinemia, coagulopathy, encephalopathy, elevated markers of inflammation, hepatic failure, and acute kidney injury. And NS1 positive, persistent positive on day 5 of illness. So it suggests that there is an initial immune stimulation which has caused this problem, and this is causing a cytokine storm. So how it can be the help in other way of managing this case. So as usual, we support the ABC fluids according to the protocol. So this is an HLH or macrophage activation syndrome, or a cytokine storm in an HLH with other organ injuries. So what will infection lead to endotoxin release? So what we have to rule out when we are treating at the source control or immune modulation or cytokine removal at that time or multi-organ support therapy, what is required in such type of patients. So steroid, definitely high dose of steroid helps in this patient. IVIG may help. So other wonderful work as there's an IL-1 blocker has shown a good response, and there is a paper from our West Bengal use of anakinra in severe dengue with refractory secondary hemophagocytosis, and this can do wonders, and this has shown a good response. So we usually support the organ failure because with the SLED or CRRT. The role of CRRT, it leads to control removal of inflammatory cytokines, correction of electrolyte-based imbalance, clearance of inflammatory mediators, and it modulates the immune function. But there are certain roles of the plasmapheresis. Initially, when we are dengue virus 1, and if it gets a second infection with dengue, same virus, type 1, you will may not have a severe infection. If you have a second type 2, the antibody which is produced by the type 2 may not be like the protective for the dengue. And this antibody, the type 2, which is going to cause more severe infection or the immunological reaction in that patient, if you have a previously with the type 1. So this patient with the immune phenomena, if you use plasmapheresis, if they have a severe organ dysfunction, it does a wonder. You do a plasmapheresis and you use these for hyperferritinemia. You can use the drugs like an IL-1 blocker or the others, the CRRT multi-organ support. These patients can come out. There are definitely evidence of plasma exchange in combined therapies with dengue-associated acute liver failure, the similar which we used in our patient and had shown the good response. So we did plasmapheresis, CRRT, and cytosorb. The cytosorb is the filter which absorbs the cytokines in initial phase, and we have suppressed the cytokines by giving methylprednisolone and anakinra. So this patient has shown the wonders, and the ferritin has come down significantly. The coagulopathy has improved, encephalopathy has improved. So these are some few subset of patient. We have to think there is something else severity for a dengue. It is not the plain dengue. It's a plain dengue which is going into cytokine storm, and such type of therapy may help in this type of patient. So this is just to stimulate the thinking thought process for all of us. So there are the other therapies which can be used apart from just fluid management in the dengue for patient who had severe organ dysfunction, and this patient improved. There was no other setbacks and went home. So, and the bed storming goes on till we get such type of patient. Thank you. Never stop learning. With every patient, we learn something else. Thanks for everyone and for giving me an opportunity to speak here.
Thank you very much, Dr. Paramanand sir, for this excellent, rare, at the same time, very useful eye-opener for the practicing pediatrician. The tough typhoid, which needed at the end due to the hemolysis, the plasmapheresis, and the second one, of course, the devastating disease, which is treated very well with the biological, and of course, the common dengue lead up in an immune mediated. So all these three scenarios will be very beneficial to all of us and the practicing pediatrician. Thank you so much.
Thank you, sir.
Now we'll move on to the fourth topic of this curtain raiser program of IAP Tamil Nadu. Now I invite my associate, that is, I know her when I was doing my as a president NNF in Tamil Nadu, in Chettinadu, South Neocon, Dr. Aparna, who is a clinical director neonatology in Hyderabad. He is interested in various specialty like neonatal ventilation, CPAP, and nutrition. And this particular topic, that is non-pulmonary causes of respiratory disease, it is a very important topic for those who are treating with the neonate in their practice. And over to Dr. Aparna for your talk.
At the outset, thank you so much to the organizers of this curtain raiser. Thank you, Dr. Jalil sir, for your kind introduction. I hope the audio and the slides are clear.
Yes, madam. Yes, madam. Go ahead.
Thank you, sir. So, as Dr. Jalil introduced, I am from Tamil Nadu. My roots are from Chennai, and after completing my MD from PGI and DM training in neonatology, I worked briefly in Chennai before I moved on to Hyderabad, and currently I'm associated with KIMS Hospital there. In this session, I'm going to be discussing few interesting case-based scenarios to highlight the importance of non-pulmonary parenchymal etiologies for respiratory distress in newborn. We all know that respiratory distress, which is a syndromic terminology used for a newborn who is presenting to us with tachypnea, retractions, work of breathing, with or without oxygen requirement. So this can be the presentation of various conditions and not just pulmonary parenchymal problems. And this is just a kind of an eye-opener to some different causes for respiratory distress. I'll begin straight away with the first case. So this newborn was a 36-week boy with a birth weight of 2,700 grams delivered by LSES. It was an unbooked pregnancy. The mother is a primey and a non-consanguineous couple. So the baby is delivered and has Apgar scores of 4 and 5 and requires resuscitation, develops severe respiratory distress and cyanosis right at birth, and requires delivery room intubation. So on examination, the baby has a Silverman-Anderson score of 2 to 3 divided by 8, and the air entry is reduced, particularly on the left side, with a scaphoid abdomen. So in this newborn, we have two important clues: differential air entry and the presence of scaphoid abdomen. When we see both these clinical signs, one of the strong differentials is a diaphragmatic hernia. If we had only seen asymmetrical air entry or hyperinflated chest, then we might have also considered pneumothorax, which is one of the complications because of a delivery room resuscitation. But we also have the clue that the baby had scaphoid abdomen, and this X-ray done in this newborn did confirm the presence of a left-sided congenital diaphragmatic hernia. We know that 85% of the times babies have a left-sided Bogdalex hernia presenting to us with a diaphragmatic hernia, and we can see the evidence of air-filled bowel loops in the left hemithorax. There is also varying degree of mediastinal shift, both cardiac as well as a tracheal shift to the right that can be appreciated. It is always good to get an X-ray with the nasogastric tube in situ so that we can appreciate the extent of mediastinal shift. Now, although this is pretty classical and a pretty relatively straightforward diagnosis once the X-ray is performed, it might be challenging sometimes, especially when we get the X-ray soon after birth, when the bowel loops are not yet filled with gas. So although this is the X-ray that we classically see, where you can see that the NG tube is displaced towards the right side, the endotracheal tube is also pushed towards the right because of the bowel loops occupying left hemithorax. And you obviously see the bowel loops in the left hemithorax. This classical picture takes few hours to evolve and few hours for the gas to reach significant extent of the stomach as well as small bowel loops. The X-ray on your right is also a case of diaphragmatic hernia involving the right side, and this X-ray shows almost uniform opacity of the right hemithorax, unlike the classical picture of gas-filled bowel loops, which is only seen appreciated after a few hours from birth. So this can be the presentation when the X-ray is done very early and can sometimes be mistaken for a pneumonia, consolidation, early onset sepsis. Sometimes we might think that this could be a pleural collection of fluid like a congenital pleural effusion. So this requires a high index of suspicion, and sometimes we may also be able to appreciate some signs like the presence of bowel sounds in the hemithorax. So diagnosis in CDH is possible in prenatal scans, but even today, after the advent of excellent scans, still up to 50% of cases of fetal diaphragmatic hernia may not be picked up in the antenatal scans. But if they are associated with other abnormalities such as cardiac anomalies, then the likelihood of antenatal pickup becomes higher. The mean gestational age for identification is around 24 weeks. If it is viewed directly, one actually sees antenatally the presence of abdominal organs, intestinal loops, or gastric bowel loop in the thorax. And there could be sometimes indirect signs in prenatal scans, like the presence of polyhydramnios without any other maternal etiology, or there could be an abnormal cardiac axis which is shifted towards the right side, absence of stomach in the abdomen, which may also be seen with babies with esophageal atresia, and the presence of peristalsis in the thorax. So these could be some indirect signs of the presence of diaphragmatic hernia in the fetus. Now, when diagnosed antenatally, sometimes as pediatricians, we are called for antenatal counseling. So if antenatal diagnosis is done prior to 25 weeks, or if it is associated with some other signs, particularly the lung-head ratio, or LHR, less than 1. And these days we use the observed to expected lung-head ratio as a proportion. And if this is again less than maybe 50 to 55%, this can be indicative of significant pulmonary hypoplasia, which is a very important marker of poor prognosis. The other markers of poor outcome include the presence of high drops, the presence of liver as the hernial content, and associated left ventricular hypoplasia. Postnatally, newborns may sometimes present as a complete surprise with very early onset respiratory distress. Although the onset of respiratory distress can be postponed by many days, sometimes weeks, if the hernia is relatively small and insignificant in size, this could happen. But most of the large diaphragmatic hernias will present very soon after birth with respiratory distress, cyanosis, decreased oxygen saturations in room air, and the clinical evidence of mediastinal shift, such as the heart sounds being audible on the right hemithorax, as we discussed, scaphoid abdomen. There could be some degree of hyperinflation of the hemithorax that is involved, and on auscultation, sometimes it may be possible to auscultate bowel sounds in the hemithorax. Chest X-ray with the feeding tube in situ is diagnostic in majority of the cases, and sometimes we may have to also get an ultrasound abdomen to differentiate other conditions. The management of diaphragmatic hernia has become fairly standardized now with excellent protocols available. Institutional delivery is strongly recommended, of course, in tertiary care centers wherever antenatal diagnosis has been made, in order to avoid postnatal transfer in these babies with hypoplastic lungs, particularly if they are ventilated at the referring center. It might be difficult to shift the baby because they are at high risk of developing air leaks and pneumothorax. When diagnosed antenatally, it is important that in the labor room, bag and mask ventilation is avoided. The baby must be stabilized with appropriate ventilatory support, avoiding ventilator-induced lung injury and paratrauma. There is a role for delaying surgery until hemodynamic stability is achieved, and usually surgery is not performed in a rush, particularly definitely not before 24 to 48 hours. This is the time when pulmonary pressure is also stabilized. These days, thoracoscopic surgery or laparoscopy, minimally invasive surgery, is also being performed for small defects, provided the baby can tolerate some degree of pneumothorax that is induced during laparoscopic surgery. And primary repair may lead to restricted diaphragm function compared to patch closure. And there is a certain small risk of recurrence that is seen. It is important as neonatologists and pediatricians that we are aware of the gentle ventilatory strategies, both pre and post-operatively in diaphragmatic hernia. We should remember to minimize paratrauma, avoiding high pressures more than 20 centimeters of water, and over-distension of the lungs because they are very vulnerable to develop pneumothorax. Practicing permissive hypercapnia, allowing PCO2 levels to build up to 60-65 millimeters of mercury, provided pH is more than 7.25 and the baby is hemodynamically stable, accepting pre-ductal saturations as long as they are more than 85% with adequate perfusion. All these steps are important to prevent the occurrence of ventilator-induced further lung injury. Minimal sedation, the early use of high-frequency oscillation whenever peak pressures more than 20 or mean pressures more than 10 to 11 are indicated might also be important and appropriate in diaphragmatic hernia. The role of ECMO is still controversial. Survival in babies who require ECMO is still not very encouraging, but this is one of the therapeutic strategies in refractive hypoxemic respiratory failure secondary to CDH. Now, sudden deterioration in a baby with diaphragmatic hernia may occur due to worsening persistent pulmonary hypertension, and sometimes babies develop this complication, which is a huge tension pneumothorax. Not only is it common on the ipsilateral side of the hernia, but can sometimes seen also in the contralateral hernia because of the presence of bilateral significant pulmonary hypoplasia. And post-operatively, deterioration can sometimes occur because of the abdomen compartment syndrome. Once the hernia or the defect is repaired and the abdomen contents are pushed back into the abdominal cavity, which is relatively underdeveloped in these fetuses, babies are at risk of abdomen compartment syndrome. Usually this resolves spontaneously. Sometimes intravesical abdomen pressure monitoring is kind of practiced in order to monitor the abdomen pressures, but this is usually self-resolving. Babies require good decompression of the upper gastric compartment by regular NG aspiration, and rectal washes or enemas may sometimes be useful for lower gastrointestinal decompression as well. Not just diaphragmatic hernia, there could be other pulmonary malformations which may become symptomatic in the early neonatal period. Most of them become symptomatic relatively later in infancy or in childhood, but occasionally we may have a case of a cystic pulmonary adenomatoid malformation that is seen in this particular X-ray. This is characterized by multiple hypolucent cysts that are visible sometimes in the chest X-ray, but more commonly we may have to perform a CT for identification of a CPAM. And this is something that requires resection whenever the baby becomes symptomatic in the form of respiratory distress or recurrent infections, or even if the child remains asymptomatic, one might plan for a elective resection between 3 to 6 months because of the high risk of transition to adenocarcinoma, and survival is generally excellent. Another pulmonary malformation which we'll be seeing in the next case is this. This was a 3 weeks newborn who presented to us with low-grade fever and breathing difficulty. On examination, the baby had tachypnea with respiratory rate of 70 per minute with mild recessions, and air entry was reduced, particularly on the left side, and there was no abnormal cardiovascular finding. This was the admitting X-ray. The admitting X-ray does show that there is significant hyperinflation of the left lung. There is herniation of the left upper lobe into the mediastinum. You can see that the mediastinum is being pushed to the right side and a relatively collapsed right lung. However, at this point of time, treatment was begun in terms of a viral bronchiolitis. A possibility of a mucus plug causing some degree of hyperinflation of the left upper lobe was also considered. However, because of persistent X-ray picture, this baby was subjected to a CT chest evaluation, which confirmed the presence of massive hyperinflation of the left upper lobe and herniation, which can also be appreciated actually on the X-ray films. And this was diagnosed as a case of congenital lobar emphysema based on the CT findings. And this is again one of the common ways of presentation of CLE. Not all cases of CLE may become symptomatic right at birth. Some of them may present after varying degree, time, duration. And usually they may be initially started on treatment in lines of viral bronchiolitis. There might be some degree of hyperinflation which might be attributed to a viral infection or mucus plugging. The baby would receive HFNC or CPAP with some nebulizations, but whenever we see persistent unilateral hyperinflation, and sometimes we may have to do a bronchoscopy for confirming the diagnosis, for ruling out other etiology like mucus plug. Of course, a CT scan reported by an experienced radiologist is very handy for making and confirming the diagnosis of a CLE. Commonest lobe involved is the left upper lobe. The babies improve well post lobectomy. Some surgeons prefer to electively do a bronchoscopy in every case of CLE to kind of rule out the bronchial bronchomalacia component also, which is sometimes accompanying the lobar emphysema. Remaining part of the ipsilateral lung and the contralateral lung continue to expand and grow pretty well. ICD might be required for 3 to 4 days post the surgery, and again this condition is associated with an excellent outcome. Another pulmonary malformation also, which can rarely present, of course, in neonatal period, but very often may present later on with recurrent infections, is bronchopulmonary sequestration. So whenever we see recurrent pneumonic consolidation in the same lobe of lung, this is one of the differentials, bronchopulmonary sequestration. The diagnostic imaging of choice would be a CT angiography to identify the feeding artery, which is of systemic origin rather than pulmonary origin in classical bronchopulmonary sequestration. So moving on now to another patient, a 1 month, 3.2 kg infant presents with episodic cough and decreased feeding. On examination, the baby is pretty active. There is no fever. Vital signs are within normal limits. Heart rate, respiratory rate. There is no evidence of increased work of breathing. No localizing signs on chest examination. The chest is clear. There are no crepitations or wheeze. But the baby develops intermittent episodes of cough, which are associated with paroxysmal occurrence of cyanosis, apnea, breath holding. And during these episodes, the baby has a sudden fall in saturation as well as heart rate. On lab evaluation, the hemoglobin is 17 grams. The total leukocyte count is elevated to 35,000. So there is leukocytosis with a lymphocytic predominance, 60% lymphocytes. Platelet count is normal. CRP is not very significantly elevated. So the chest X-ray was also not contributory. The parenchyma or the lung infiltrates were minimal or absent. It looked like a essentially normal pulmonary film imaging on the chest X-ray. So on investigation, a nasal PCR which was sent turned out to come back positive for Bordetella pertussis. So this is a relatively classic presentation of neonatal pertussis. Now, with the increasing advent of waning immunity in adolescents and in pregnant women, waning immunity titers to pertussis can predispose the newborn babies to neonatal or early infantile occurrence of pertussis prior to the first vaccination at 6 weeks. Cough, whenever we see in a young infant or a newborn, is usually a very unusual symptom in general of any chest pulmonary infection. Rarely do we see cough in newborns. So whenever we see cough with this kind of paroxysmal cyanosis apnea with the lymphocyte predominant leukocytosis on the blood investigations, one does consider a diagnosis of pertussis. Untreated neonatal pertussis can be associated with very high mortality. Treatment is, however, very simple. A 5-day course of macrolide can be curative in most of the cases, and the babies respond excellently well. This brings again the point of immunizing mothers with Tdap vaccination in place of the second dose of TT, which is, I think, practiced now in most of the centers and is also aligned with the IAP position's statement on prevention of neonatal pertussis. So moving now to another case. This was a 34-weeker late preterm baby presenting with a birth weight of 2 kilograms, born to a primary mother without any risk factors for infection, presented with respiratory distress. At birth, decreased room air saturation, both upper limb, lower limb saturations were the same. They were 85 to 90%. The baby was intubated in the labor room and was shifted to the NICU, started on SIMV mode of ventilation, required very high pressures to move the chest, 20 by 6 PIP by PEEP. It had to be increased up to around 24 PIP and PEEP of 7, and the baby required FiO2 of 100% to maintain saturations, and baby had to be switched to high frequency ventilation electively. Now, as we would have done in most of the scenarios, an X-ray was done. It showed bilateral uniform opacity or ground glass appearance, and RDS was suspected and a dose of surfactant was given, which is what most of us would have done in this scenario, but there was absolutely no improvement in the baby's oxygenation, the pressure requirement. The baby's lungs were pretty poorly compliant, and there was very minimal chest rise and continued to require high pressures. Antibiotics were initiated. A sepsis screen which was done was negative. Blood culture came back sterile, and by 24 hours, the baby remained status quo with no improvement, no significant improvement. Saturations, despite high pressures on HFO and almost maximal FiO2, remained 85 to 90%, both pre and post-ductal. An echo was done on an urgent basis, and it confirmed the diagnosis of a supracardiac obstructive TAPVC. So this X-ray, a HMD-like X-ray, bilateral whiteout lungs, reticulogranular shadows. Sometimes we may see occasionally air bronchograms. particularly when we see no response or very minimal response to high pressures, high oxygen, and therapies such as surfactant. One suspects whether we are dealing with RDS mimics. One of the commonest mimics that we see is important, I would say, not very common, but extremely critical condition is obstructed TAPVC. When identified and treated early, the good thing is most of the critical cyanotic heart diseases in newborns, including TGA, TAPVC, have close to 80% survival in good cardiac centers. So the message here, atypical
Dr. Aparna,
course
another
of...
5 minutes.
Yes, sir. Yes.
Another 5 minutes.
Sure. Atypical course, unusual severity, suspect CHT, and one has to remember that not critical heart disease, not all will have murmurs, and some exceptions are Al-Kappa, TAPVC, TGA, and critical pulmonary stenosis. So we may expect critical heart disease even in the absence of murmur. So these are some signs to differentiate whether respiratory distress is of cardiac etiology, presence of minimal signs of work of breathing. The cyanosis can be usually milder in pulmonary and more severe in cardiac conditions. The presence of differential cyanosis wherever present is again strongly indicative of cardiac. Very importantly, no or minimal response to oxygen, no or minimal response to surfactant, high pressures, worsening cyanosis on crying. And these can be some signs of cardiac involvement. Likewise, in the blood gas, normal or low PaCO2 levels and minimal response in the PaO2 to hyperoxia test and presence of predominant metabolic acidosis are some of the clinchers for a cardiac cause of respiratory distress. We all know that in TAPVC, pulmonary veins confluence drains wrongly into the right atrium instead of the left atrium, and this also tends to be obstructed. So this is the supracardiac type where the four pulmonary veins drain through an accessory or a common cardinal vein into the SVC, and they are obstructed either at the confluence or at the level of the PFO. In contrast, in the infracardiac type, the pulmonary veins would be draining through the IVC back into the right atrium. And again, in this case, they are more likely to be obstructed. So we do TAPVC repairs at our center. This is a baby who is recovering from TAPVC repair. Usually they are managed in the post-op ICU with ventilation. Mediastinal and pleural drains are placed and an elective peritoneal dialysis is performed in the first 48 to 72 hours with close monitoring for episodes of pH crisis. I think I'll conclude with this last case, sir. Case 5, 15-day-old baby born full term, 3,200 grams, male baby born to a gravida 3 mother with one previous neonatal death. Cause was not clear. The baby presented with respiratory distress, lethargy, and poor feeding. On day 15, the weight was still below the birth weight, and the baby had significant hepatosplenomegaly. So the baby was admitted. The blood gas showed severe metabolic acidosis. pH was 7.0. Bicarb was low. PCO2 was actually low normal. Sepsis screen, which was performed, showed leukopenia and thrombocytopenia. So the admitting diagnosis was late onset sepsis. The baby was begun on broad spectrum antibiotics. A CSF was done to rule out meningitis, which showed absolutely normal CSF picture. On probing the history, the previous baby had had seizures and died on day 21 of life. And that baby also had high anion gap metabolic acidosis. The index baby's anion gap was 24, which was elevated. Ammonia was slightly high at 160. Lactate levels came back normal. Other workup for torch infections and intracranial bleeds, etc., came back negative. So we did a tandem mass spectroscopy suspecting an inborn error of metabolism, and it showed elevated C3 acyl carnitins, quite classical of propionic acidemia. The baby was started on special diet and was discharged with the propionic acidemia diet. As always, the teaching would be one should go on to and try to establish genetic diagnosis in all these cases, which was done. And the baby's genetic workup came back as a dual heterozygous or compound heterozygous for two genes responsible for propionic acidemia. Both of these are pathogenic variants. So whenever we have a family history, consanguinity, sibling death with high anion gap metacidosis, even if they present with other signs like respiratory distress or seizures, one always tries to look for an inborn error of metabolism, not stopping with the biochemical diagnosis, but always trying to establish the genetic diagnosis. This was another case, a baby who presented with hypotonia, macroglossia, and hepatomegaly with cardiomegaly, with ECG showing giant QRS complexes and short PR interval, biventricular hypertrophy, which came back positive for Pompey's disease. A quick diagnosis can be established by looking at alpha glucosidase lysosomal enzyme levels, and of course, confirmatory testing would be possible by the molecular genetic studies. When diagnosed early, before neurological symptoms have set in, enzyme replacement therapy is quite curative in glycogen storage disorder, but unfortunately, in some organic acidemias, like the case of propionic acidemia that we saw, the prognosis may not be very reassuring. So I think I'll leave this flow chart for the view of everybody. This is something that is often discussed, and I'll straight away move to the take-home points. So there are some other cases. This is a cleft palate presenting with recurrent pneumonias. This was a case of CMV infection presenting with postnatal pneumonia in a immunocompromised extreme preterm infant, which was treated with ganciclovir. A baby with an airway involvement, which was an epiglottic saccular cyst presenting with recurrent extubation failures. These are the other differential diagnoses. And a baby with a duct-dependent systemic circulation cooptation. And the last scenario was a pericardial tamponade associated with a PICC line, a case of CAH presenting with respiratory distress. So there is a long winding list of causes for respiratory distress in newborns, not just pulmonary, but we have cardiac, we have rhythm disturbances, thoracic causes, neuromuscular diseases, the anatomical defects like cleft palate, non-bacterial viral infections, or infections like pertussis mimicking as a regular bacterial sepsis and pneumonia. So one always needs to approach systematically, stepwise, keeping clinical signs, laboratory investigations all into prudence and for making an appropriate diagnosis. Thank you very much for this opportunity.
Thank you, Dr. Aparna, for the excellent flow of case scenarios. Of course, you have highlighted the surgical causes of the pulmonary respiratory distress, which is a bread and butter for all the practicing pediatrician and the neonatologists. The cases CDH, CLE, CAM, and TAPVC, all are, a nightmare for the attendees, neonatologists. And thank you so much for your participation and presentation. And we will take, there are some questions in the chat bar. What happened in the delivery room if the bag and mask is applied and the subsequent development of the pneumothorax, how I can manage?
In cases of diaphragmatic hernia, although generally we say bag and mask ventilation is contraindicated, sometimes we may not have the benefit of antenatal diagnosis. Bag and mask ventilation may be associated with a higher risk of developing barotrauma and pneumothorax, and this needs to be remembered. And we will just have to manage it on the similar lines to pneumothorax in a baby without CDH. So insertion of a needle thoracentesis can be life-saving. This can be followed by the placement of an intercostal drain.
In an antenatally diagnosed CDH, will you prime the neonate before taking her for a surgery? Because the PPHN or subsequent hyperplasia is a nightmare for all of us. Do you always do some priming?
Priming for the mother, sir, or
baby,
preparation?
For the baby, for the neonate in the delivery room.
So, I think in terms of priming, I'm not sure if antenatally, if any such strategy is available. There are antenatal therapeutic measures like exit treatment, but that is still not something that is very often practiced in India. But a good team preparation, shifting the baby antenatally in utero to a center where CDH is routinely managed, and the treating team of pediatricians, neonatologists being ready for everything, including an ICD placement in the labor room itself, being aware that this is CDH and being ready to straight away intubate and start bag and tube ventilation rather than bag and mask are some of the steps.
Thank you, Dr. Aparna, for your presentation. Dr. Nandini, Dr. Jayavardhana is here. Would you ask him to? Dr. Jayavardhana.
Dr. Jayavardhana is the organizing.
Good evening, everyone.
Dr. Jayavardhana, a few words, please, on behalf of Kongu Pedicon, Tamil Nadu State Chapter.
Good evening, everyone. So I'm happy to meet you all again. This is curtain raiser CME of Kongu Pedicon. And regarding the next topic, so we have initial management of emergencies, pediatric emergencies. So we all know that emergencies demand speed, clarity, and confidence. So this draft going to guide us through the essential first actions which we should do in the case of emergencies. Let us welcome our speaker and give them our full attention for this important session. Over to you, Dr. Swati.
Thank you, sir. I really congratulate the Kongu Pedicon team for arranging this wonderful, I think it's a last minute CME, which is really amazing how you have put it up. And I'm grateful for selecting me as one of the faculty. So as a pediatric intensivist, what I want to say as a starter is that what we receive.
I can rejuvenate myself.
Dr. Jalil, please mute yourself, please.
Yeah. So what I can say is I receive patients in a different shapes and sizes, and in the last 5 years, what I've seen is the patients who have been resuscitated well in the peripheral nursing homes by the primary treating pediatricians. When I receive them, I'm the happiest because the initial resuscitation, the child transport is very safe, and the child withstands the transport and reaches my hands very safely. So in that scenario, we are also very happy to further resuscitate the child and manage the child. So I just want to, with this presentation, I want to focus on how important is the initial management by the primary treating pediatrician before referring to the child. So I'll just share my PPT. Is the PPT visible?
Yes. Yes, doctor.
Okay. So greetings from the coastal city Mangalore, which is right opposite to the coastal city Chennai. So the objectives of this presentation will be the case-based approach to diagnose common emergencies in pediatric practice, especially the ones with very high mortality, the emergency management of common emergencies in your ER or OPD practice, and when and how to safely refer these patients. So just quick recap of PALS, we all do this pediatric assessment triangle where we see the appearance, work of breathing and the color of this child. And if any of these are unstable, then it is a life-threatening problem. We have to intervene immediately before going to the primary assessment. Primary assessment is our age-old ABCDE quick assessment, which takes within 15 to 30 seconds. We have to finish our primary assessment and ask how is the airway, whether it is clear, maintainable, not maintainable, breathing, what is the rate, effort, chest expansion, lung and airway sounds, and what is the saturation. Circulation wise, we have to see the heart rate, attach the chest leads and see the rhythm, pulses, capillary refill time, skin color and temperature, and blood pressure. Disability wise, do not forget to see the posture of the child and pupils and AVPU, and also the GRBS. Exposure wise, just look at the temperature and undress the child and look for any rash or bruise. After that, you proceed to secondary assessment. So directly going to the first case. So this was a 2-year-old girl who presented with, she had just a URTI, cough, cold, fever since 2 days. But since the last 12 hours, she was really irritable. So on examination, she had tachypnea, she was looking pale and irritable. So at this juncture, we definitely know that this child is having some circulatory issues because she was looking pale and she was tachypnic. So here immediately, what we have to do here immediately is establish an IV line before going to further management, and of course start on an RBM. So if going further, the airway was clear. The respiratory rate, she was tachypnic and tachycardia was there, and BP was normal, and poor peripheral pulses was there. So, and she was febrile as well. So what is the next? And she had some rashes. What is the next? So we have to do the physiological diagnosis before moving further. That is, this child has definitely has respiratory distress and she's in a compensated stage of shock. So how to proceed further? So we have to here, since she is having respiratory distress, definitely we have to start on her high flow oxygen. What I find is the doctors start on nasal cannula or the doctor start on face mask oxygen, please, these kind of children who have respiratory distress should be started on NRBM before shifting. And she is a child who is compensating herself because the BP is still normal. So coming to sepsis in children, this whole scenario looks like a septic shock status. The prevalence of severe sepsis and septic shock among the hospitalized children is 1 to 26% with a very high mortality of 35% in developing countries, whereas the mortality is just 5% in developed countries. Why is that so? Main thing is delayed recognition and treatment significantly contributes to the mortality even in this age. So what are the stages of shock? The compensated shock, where the child maintains the end organ perfusion, BP is maintained only by increasing the heart rate, and uncompensated state where the microvascular perfusion is finally decreased and signs and symptoms of end organ dysfunction is started and the child is hypotensive. Whereas irreversible stage is progressive end organ dysfunction and the already cellular death and cellular acidosis is there. So we have to make sure when we receive the child with compensated shock, we have to treat optimally so that the child does not progress into further stages. So how do we treat this? Main thing is you have to increase the oxygen content in the blood of this child, and also you have to increase the cardiac output and the blood pressure somehow. So what are the things we have to do? One is, as I already told, start the child on NRBM and fluid bolus. So the consensus about fluid bolus is changing year by year, and we intensivists are becoming more and more conservative about the fluid that we give in a child within a compensated shock and not hypotensive shock. So this is the Survival Sepsis Guidelines 2020, which says that in healthcare system with availability of intensive care, where you have NIV, you have invasive ventilation available, you can be little liberal with the giving of fluids. That is, you can give 10 to 20 ml per kg bolus over the first hour, titrated to the clinical markers. So, but in a healthcare system with no availability of intensive care, in the absence of hypotension, we recommend not to give any bolus. Maybe you start dehydration correction and give a slow bolus of 10 ml per kg over 1 hour instead of the push and pull technique. But if the child is hypotensive, then we can start the bolus and refer the child as soon as possible. So then what in all the centers nowadays we see what is the underlying problem in this child instead of giving bolus and starting off the inotropes. So within half an hour of admission of such children, we do the POCUS, that is point of care ultrasound, to see the pump, the tank and the pipes. That is, the pump is a contractility, whether the child's cardiac musculature is involved and if the sepsis induced myocardial dysfunction is there. So we can do a eyeballing technique and within few seconds we can find out whether contractility is good. Then we see the IVC. So if the IVC is full or empty. So if the IVC is full, then that indicates that there is cardiac dysfunction. Also, the child has received enough fluids and there is no need of further fluid administration. And then we do the calculation of SVR by seeing if there is a narrow SVR or a wide pulse pressure. If the SVR is narrow, this child is in a compensated state and require more fluids, where if the SVR is wide, then the child requires inotropes. So in septic shock, all the components will be there. That is overactive pump and dilated pipes, and in the later stages we can have myocarditis and failing pump. So all the components will be there. It can be different combinations in a child with septic shock. So always we have to assess both the pump, the tanks and the pipes. So coming to the management, mainly it is the fluid management and continuous hemodynamic monitoring. So more and more we see whether the child is tolerating fluid and responding to fluid. So after giving 10 ml per kg bolus over half an hour to 1 hour, we keep auscultating this child for development of crepitations, and we use POCUS to see whether there is lung B lines in the lung, whether the lungs are getting overloaded. So then we move forward and decide on what next. So this is the algorithm which we follow, where the initial we have already covered. So without hypotension, we give very slow 10 ml per kg boluses over half an hour to 1 hour. And if abnormal perfusion without hypotension, we do not give fluids, maybe start on maintenance fluids. And if the child remains hypotensive after giving the bolus, then we consider which inotrope to start, which vasoactive medications to start. So if this child is having a cardiac dysfunction, the first line of inotrope that we use is epinephrine. If the child is not having cardiac dysfunction, having wide pulse pressure and high SVRI status, then low SVRI status, then norepinephrine is treatment of choice here. So if you are very clear that this child is having bounding pulses, wide pulse pressure, then the norepinephrine is the drug of choice. Whereas if there is child is having cold peripheries and with cardiac dysfunction, epinephrine is a drug of choice. So if we start this much, give a bolus, start on NRBM, start on the vasoactive agents before shifting the child to higher centers, the mortality can be significantly reduced. Another important thing is the administration of antimicrobial agents. So this was a randomized control trial done where they compared the duration from the diagnosis of septic shock and the administration of antibiotic. So every hour delay in the administration of antibiotic after the time of onset of hypotension, the mortality increased by 7.6% in the first 6 hours. So each hour is very important. It can the timely administration of antibiotics can reduce the mortality by 7.6% every hour. So these are the things which bundles which are made to remember things very easily. So when you receive a child with a septic shock, you can give 3 things and take 3 things. That is, give high flow oxygen, give fluids, and give the first dose antibiotics. Take 3 things, that is, check the sugar levels, because hypoglycemia can significantly increase the mortality in these children, and take the blood culture and the ABG. So just few remarks on the dengue shock. The pathophysiology is completely different in dengue shock. There is slow leakage of fluid because of capillary dysfunction. So we follow something called restrictive resuscitation, that is controlled fluid replenishment, aiming for a lower limit of euvolemia. So we give a very less dose of crystalloids and target a lower normal urine output. So after giving fluids, we don't follow that WHO guidelines like 7 ml per kg per hour and 5 ml per kg per hour, then taper. So the gold standard is you monitor the urine output. As long as this urine output is 0.8 to 1 ml per kg per hour, even the maintenance fluids or even 2/3 maintenance of fluids is more than enough for this child with dengue shock. And early use of colloid, that is called colloid rescue. That is, you have given 10 ml per kg boluses 2 or 3 times, then we have to give albumin 1 gram per kg over 4 to 6 hours instead of giving further crystalloids. What is don'ts? Because giving fluid is very easy, excessive fluid administration, but later on to removal of the fluid from the third space loss, which the child is suffering from, is very difficult. The child might require renal replacement therapy like SLED or CRRT if we overload this child. So titration of fluid has to be done according to the urine output. So please use colloids early, and FFP transfusion for volume resuscitation should not be done in these children with dengue shock. So then coming to scenario 2, these are also the common scenarios which have a high mortality if the initial resuscitation is not done properly. So this is a 6-year-old boy who fell from the first floor of the building on a compound wall, and when the child was playing at home at 5 p.m, immediately noted by parents, neighbors, and they called an ambulance. So initial assessment on site was the child was conscious but screaming in pain. He had severe respiratory distress and pallor. So again, this child is having severe respiratory distress. Probably he might have a lung injury, or he may be screaming because of pain and hence having respiratory distress. He is pale. That means he has lost a significant volume of blood. So initial what we do here is we have to start a high flow oxygen like NRBM, and then we have to establish an IV line as soon as possible. So here, along with the regular ABCDE, another important thing is there. One is cervical spine stabilization. and we have to look for exsanguination in the circulation. That is how much blood is the child losing. So these two extra things are there than the regular ABCD in a child with trauma. So in this child, the airway was patent. Breathing wise, he had respiratory distress. His saturation was very low, that is 60% in room air. And he has tachycardia and BP is normal. And he has low GCS, he's irritable, bilateral pupils are equally reacting, the sugars were normal, he was unable to move the left lower limb, he had abrasions in the left leg was deformed at the level of the thigh, and he had a temporal skull swelling. So what is the impression versus intervention? So he is definitely in respiratory failure. So any child having a saturation of less than 94%, we say it is respiratory failure, and we have to support the breathing here. And we can start oxygen by NRBM. Better to avoid bag and mask ventilation here because we don't know about the last meal, and we have to keep things ready for intubation because only NRBM may not help. So he is disordered control. He has disordered control of breathing. That is, he is drowsy. So we have to make sure in all the children who are drowsy after an accident or a fall, we have to assume that he has unstable cervical spine, and you have to apply the cervical collar. And for opening the airway, we should never use head tilt chin lift maneuver. Instead, you have to use a jaw thrust maneuver. So here we have suspected a traumatic brain injury in this child. And then we have to prepare for an advanced airway and secure 2 IV access. And this is how we keep ready. So we have this Broslow's tape. You just take the length of the child because in this state, we will not be able to weigh the child. The moment you get the length of the child, so if the child's length comes in the red, all the drugs are ready with the doses. So in this child, airway patency, we have to do something called as 3-level stabilization, and you should not put a nasopharyngeal airway or NG tube because of the risk of basal skull fractures being there. So how do we stabilize the cervical spine here? As I told, always assume that the patient has cervical spine injury. Restrict the cervical spine until spine injury is cleared. We do something called triple immobilization. That is, we have a flat board with a cervical collar, and then we put 2 blocks and 2 straps across the head of the child. This is called as triple immobilization. So these are the different way in which we stabilize the cervical spine. One is manual. If you don't have a cervical collar, using your hands and forearms, you can stabilize the cervical spine, but this cannot be done for a long time. Then 1-level stabilization is using a cervical collar, and this is the triple stabilization. So what happened to our patient? Within 10 minutes after starting NRBM, and we have kept things ready for intubation, the saturation started falling. So what next? And distress is there. So we have to do a positive pressure ventilation and intubation over here. So what is the sequence of airway management? We have to do a tracheal intubation. So how do we secure the airway? So usually during intubation, the neck can move. So that should be avoided by doing something like manual inline stabilization, where you and if the cervical collar is placed in the neck of the child, will not be able to move the neck. So the second person resuscitator should hold the neck of the child while the other person is intubating this child. So this is how we do the manual inline stabilization while the second rescuer intubates the patient. So what is the indications of intubation and ventilation in a child with trauma? So persistent or predicted airway obstruction, like for example inhalation burn, even while examination, if the airway is patent, if there is a sooting of the nasal hair, and if you are suspecting the inhalational injury, better to secure the airway before the tracheal edema develops. Loss of airway refluxes, whenever the GCS is less than 8/15 in a child with head injury, better to secure the airway with invasive intubation. Disrupted ventilatory mechanism, that is, if the child is having a severe flail chest, persistent hypoxia despite supplemental oxygen, like our case, inadequate ventilatory effort or increasing fatigue, and if a child is having secondary brain injury and controlled ventilation is required. So what is the precautions that we have to take while intubating? So you have to prepare for the difficult airway management, especially if a child is having burns in the face or if there is a mandibular or maxillary injury. And with the facial injuries, mask seal will be difficult, and also administer an induction drug or sedative and a short acting muscle relaxant and intubate the patient orotracheally. So our patient, we intubated him with inline stabilization. If for induction, we used ketamine and atracurium, and we used a modified RSI and with a 5.5 mm cuff and fixed at 16 centimeters. What next? So then once the airway is stable, we went to assessment of breathing. In this child, trachea was in position, there was jugular venous distension, and there was chest wall asymmetry and bruises and open chest wounds. So, and the respiratory rate and retractions were there, and then on palpation and percussion, there was a asymmetry in the air entry in this child. So in this child, we have to look immediately for life-threatening thoracic conditions like tension pneumothorax, massive hemothorax, and open pneumothorax. So in our patient, saturation was falling in spite of intubating and mechanically ventilating the child. And the left side, there was no chest rise and there was decreased bed sounds. So what is a life-saving procedure that we can do over here is needle decompression. So left midclavicular line, second intercostal space, we did the needle decompression with underwater seal, and there was bubbling noted. So this child was stable after needle decompression. Then we moved on for further assessment, that is in circulation and disability. So circulation, the child was fortunately stable with a stable BP, and by then when we checked the pupils had become unequal and sluggishly reacting to light. By this time, definitely we have to think of raised ICP. Luckily, we have managed the airway and the breathing. Now it's time to manage the raised ICP. So what are the steps we follow in managing a raised ICP? Main thing is maintain optimal hemodynamic and respiratory support, which is already done. Adequate oxygenation and perfusion to the brain has to be maintained. The vicious cycle of cerebral edema and compromised cerebral blood flow should be avoided. So during ventilation, anyways, we have ventilated this child. We have to maintain that the saturation is always above 95%, and PaCO2 should be maintained 35 to 40 millimeter of mercury. But what has happened in this child? In this child, there is a unequal pupils, which is suggestive of herniation. So for a duration of 10 to 15 minutes, we can increase the rate of this child to maintain the PaCO2 of around 30 millimeter of mercury until the neurosurgical intervention is done. So that is called as hyperventilation technique to reduce ICP, because reduced PaCO2 will reduce the cerebral blood flow and reduce the ICP.
Ma'am, another 3 minutes.
Hypoxia should be avoided. Hypercarbia should be. So other things which we have to do is maintain the head in the midline to promote the venous drainage via the external jugular veins, and elevate the head at 30 degrees. So these are the tiers of treatment for raised ICP. First one is, as we already discussed, normoxemia, normocarbia, normothermia, normoglycemia, and elevation of head end and position head in midline. Then other tier 1B are hyperosmolar therapy. We use 3% saline versus mannitol. We prefer 3% saline because it can be titrated to target desired sodium of 145 to 155. In a child with hypotension, we try to avoid mannitol. So further, we did all these things in this child, and then we moved on to exposure. So we have to use a log roll manual for this, and then we found that there is an injury at the back. So this is one step we should never miss in a child with trauma. We have to expose the back and see what is the injuries present in the back. So in this child, our patient, there was an exsanguinating hemorrhage in the thigh, and for this direct pressure was applied. So external bleed, there are various methods: direct pressure application, tourniquet application. That should be done 40 millimeter of mercury above the systolic pressure, but we have to make sure we have to loosen it every 15 minutes and then again tie to prevent limb ischemia. So what do we do? Do we do an X-ray in this child? Yes. So if there is no posterior midline cervical spine tenderness and no evidence of intoxication, normal level of alertness, no focal neurological deficits, and no painful distracting injuries, then we don't do an X-ray. But in this child was having evidence of poor GCS, and then neurological deficits were there. So hence we had to do a radiography over here. So we use the mnemonic of nexus to determine whether this child requires an X-ray and a CT brain. So our patient, we did a skeletal survey and did a X-ray of epi and lateral views of the left side, and this child had a left mid-shaft femur fracture, and we had called the orthopedic surgeon and the neurosurgeon, and blood bank informed, and the massive transfusion protocol also was activated. So what are the questions you do before the CT scan? So the CT scan, of course, we have to do it, but the priority is the correction of other derangements. So we have to correct all the metabolic and acid-based derangements before doing the CT scan. And next question, how early is the requirement of CT scan? Is there any intracranial pathology that requires emergency surgery? Does this patient have an unstable spine that needs fixation? Does this patient require full investigation for a suspected abusive injury? So CT scan should be done if there is no other hemodynamic abnormalities and the child requires emergency surgeries. So these are the indications of CT in a head injury. Dangerous mechanisms of injury, that is high speed road traffic accident, more than 64 km per hour. Death of a co-passenger, that means this also was a significant impact. Rollover by a vehicle, patient was ejected, or fall from more than 3 feet or 5 stairs of height. So if there is a witnessed LOC of more than 5 minutes, more than 3 times vomiting after head injury, history of seizures or worsening of headache after a head injury, or GCS less than 15, depressed or penetrating skull injury. So these are the indications for CT scan in a child. So then after doing this, we do a cervical spine cuts also if we are doing a CT. But if at all we are not doing a CT, how do we do the cervical spine clearance? So if the patient becomes awake, alert, and he is sober, neurologically normal with no neck pain, midline tenderness, able to move neck in all directions, then we can remove the cervical collar with our clinical assessment only. So if at all these things are not there, then we go ahead and do a CT spine. So if the child is having neck pain, midlines and tenderness and as I told already, the previous indications of CT spine, we go ahead and do a CT spine and look for bony deformity, fracture of the vertebra, loss of alignment of the posterior aspect of the vertebral bodies, and then increased distance between the spinous processes, narrowing of the vertebral canal, or increased prevertebral soft tissue space. Or if there is any of these in the CT spine, we have to not clear the CT spine and go for spine consultation. If any of these deformities are not there in the CT spine, then we can remove the cervical collar safely. So in our child, orthopedician arrived, long leg cast was put and to reduce the pain. So
Madam, your time is past, madam. Another couple of minutes.
Okay, sir, fine. So surgery once the patient is fit and ICP is normalized. So again, if there is a limb fracture or limb surgeries, the child has to be taken for surgery only once the child becomes neurologically okay and the ICP is normalized. So pre-operative, we have to take informed consent, and then prophylactic antibiotics were given. In this child, prophylactic antibiotics were given mainly because femur fracture was there. Post-op, the child was extubated, the left-sided ICD was removed, and the plan was continuing for ventilation, and if there is no bleeding, then monitor. So this child, after the ICP was managed, then the child was taken for ortho, and then child made a good recovery with mild right hemiparesis. So I think I don't have time for case 3, so I'll directly go for take-home messages. So what are the take-home messages? The recognize early signs of respiratory and circulatory failure before referring the child to a higher center, and most of the pediatric arrests are preventable. Ensure effective airway management and circulatory management, and start early the vasoactive agents which can be life-saving in shock. We have to follow protocols and stay updated with the guidelines, and continuous learning to save the lives. And thank you.
Thank you, Dr. Swati, for this excellent talk. You took us through the child with the accident and the injury, a very, very well discussed case. Though we were not able to go through the other case scenarios due to want of time. Thank you, Dr. Swati. Excellent talk.
Thank you, sir. Thank you, ma'am.
I would now go to the last. Are there any questions? Are there any questions in the chat box?
One question in the chat box, Dr. Swati.
Yeah.
Yes.
Early use of collide in an ICU setting in the shock.
Yes. So, especially in dengue, what happens is there is a lot of endothelial dysfunction and there is capillary leak. So, more amount of crystalloids we give, it is going to go for third spacing in the lungs and in the intra-abdominal cavity. So what happens is, as we all know, when we give crystalloids, only 1/3 of the crystalloid stays in the intravascular space, 2/3 goes to the interstitial space. So especially if you're thinking not only dengue, sometimes we get severe sepsis with endothelial dysfunction, rickettsial infections, so leptospirosis, these kind of cases where there is evidence of pleural effusion and ascites. So we have to, after giving 2 boluses of crystalloids, the third bolus should be of a colloid. So the colloid how we give is 5% albumin we give. So we give 5% albumin 1 gram per kg over 3 to 4 hours. The reason being it stays in the intravascular space.
Before we...
Ma'am, excuse me, ma'am.
Yes.
After every time giving bolus, we have to reassess the patient, and if still shock persists, then only we go for colloids.
Yes,
Am I right?
Yes. So most of the dengue patients, if you have received the patient early, with 1 bolus, they usually come up because they are not like hemorrhagic shock where they are losing the fluid very fast. They are losing the fluid very slowly. So 1 10 ml per kg bolus, usually their BP up.
Yes, ma'am.
So no need to give any further boluses if the BP picks up.
Okay.
Dr. Nandini, before we go for the next session, I can acknowledge the presence of our Dr. M. Ramasamy, sir. Sir, are you there? You want to
Yes, sir.
Please, sir.
He's a senior most pediatrician, our guru and teacher.
No.
Dr. Ramasamy, please a word from you, sir.
I think congratulations to both of you. You have chosen some excellent speakers. All the speakers have done extremely well. The subject is very well updated. And, as a general pediatrician with 60 years experience, I'm beginning to feel I'm learning almost every moment. And because all the speakers have done extremely well, and all the points mentioned are very, very valid, extremely valid points they have mentioned. So thank you for organizing this type of a session. Thank you.
Thank you, sir. Thank you. So today, now we come to the last session, that is of the curtain raiser CME, and we have none other than Dr. Anurag Agarwal. Dr. Anurag Agarwal is the professor and HOD of the from the Department of Pediatrics, Maulana Azad Medical College and the associated Lok Naik Hospital. And sir has been the executive board member of the of Delhi CIAP, and then he's been at present he's one of the members of the ACVIP of IAP, that is the Advisory Committee on Vaccine and Immunization Practices. He has got excellent what knowledge about rabies. All about rabies is the topic that would be apt for Dr. Anurag because he is the founder secretary of the consortium against rabies. So over to you, sir.
Thank you, ma'am, for the kind introduction. And I would first of all thank the organizers for having me on this platform. Is my slide visible?
Yes, sir. Yes, sir. Please go to slideshow, sir.
Yeah, it is full screen.
Yes, sir. Yes, sir.
Okay. So I am the last speaker of the day, and after 3 hours, I know most of you will be exhausted from the amount of knowledge you have gained from the past speakers. So what we plan to do today now is that we try and keep this session interactive. Interaction is a bit difficult online, but you can always post your answers in the chat box. So I'll keep writing questions here and there on the slides, and then you can post your answers in the chat box, and we can discuss the questions as we go down the presentation. Because rabies is a very controversial topic nowadays, there are lots and lots of queries arising from all the pediatricians. See, the incidence of animal bites is around 2.5%. That means 2.5% people are bitten every year. This is the annual incidence. So, taking a very gross or a rough kind of a statistics, in 10 years it is 25%, and in 40 years it will be 100%. So, if we live to 80, be sure that you'll be bitten by a dog at least 1 to 3 times. So, this is the situation. So, everybody is going to be bitten one day or the other, and you will have to go to you will get patients day in and day out on dog bites, and the dog does not tell you where it is going to bite and how you are going to be exposed. So there are n number of variations in rabies or dog bites, and we try and keep to the guidelines and try to answer these questions. So today there are what we'll discuss is some case scenarios. There'll be some passive immunization, intradermal route, re-exposure prophylaxis, some wound infiltration videos, some WHO recommendations, and a slide on One Health approach. Because what happens is everybody says it's so easy to remove rabies, just kill all the dogs or just remove them from the streets. So easier said than done. So what actually can be done, we will discuss in 1 or 2 slides because I just have 30 minutes and I'll try to do justice to the time given to me. So this is your first question. All the participants who are hearing me, you can answer in the chat box. Parent calls you up in the evening on Saturday, or maybe you can make it a Sunday morning if you keep Sunday morning off. The basic purpose of keeping Saturday was in government setup, Saturday evening to Sunday is off and you come back to duty on Monday. So you can consider it a Sunday morning if you are in private. And the family tells you that the son is bitten by a dog and 1 or 2 drops of blood have appeared at the side, just 1 or 2 drops at the side, nothing more than that. And they send you a pic maybe, and it's just a red dot, if you can see on the picture. And now the question is, when should you report to the OPD and what all instructions would you want to give? So you can type the answers in the chat box. Let us see what answers we get.
Immediately to the ER.
Okay, immediately to the ER and
immunization, because category 3 requires immunoglobulin and vaccine.
Very good. So you should report to the emergency. So you should know in which emergency at night you have the availability of immunoglobulin and management for dog bite. Somebody who knows how to manage the bite. So I'm getting the answers. Wash the site and come within 24 hours. Nothing wrong with that. Wound washing, so important. And I think everybody is writing washing the wound with soap and water. This is excellent. The question was, what is the site, ma'am? It can be anywhere on the thigh, maybe. And it doesn't make a difference, I believe, wherever the dog is bitten. To report immediately to casualty somewhere and get ARV and rabies vaccine. Very good. Excellent. So this is the expected response. So the message here is that you should know where these things are available nearby to your workplace. Okay, so now moving on. The parent says, but my child has been bitten by a pet dog. And I went to the veterinarian, and the veterinarian told me that he's given the vaccine to prevent rabies, and now nobody requires to do anything if the dog bites. How do you decide treatment? What do you do? So, quick response.
Sorry, in spite of dog vaccinated, we should give ARV, I think.
Okay, so in spite of dog vaccination, you should give the complete treatment, whatever is the treatment. Then the attendant says, what is the sense of getting a dog vaccine if I have to spend money on complete treatment also?
Because even if the dog has got complete vaccination, whether it is got fully immunized, we don't know.
Yeah, there can be vaccine failures.
Yeah,
Seroconversion is not 100%.
Yeah, excellent. So what ma'am has said is very right that because the dogs, although you have vaccinated the dog, the immunity, if it has developed or not, we do not know. And the amount of immunity developed is to the level of tune of 60% in dogs whenever they are given vaccines in a country like India. So therefore, when you have only a protection level of 60% in dogs at 6 months, it is always better to go for a complete post-exposure prophylaxis. And it is always advisable to take a pre-exposure prophylaxis whenever you are bringing a pet dog at home. Right. So I think we have answered this question very well. And let's move ahead. So rabies is reported from all over the country except Lakshadweep and Andaman, and I think the answer everybody knows is now very simple because there is a distance of 1200 kilometers. It takes 10 to 12 days to reach these islands, and by the time a dog develops rabies, he is thrown into the sea, and therefore rabies did not reach these islands till date. Yes, there was a case which was reported. I was called up, in fact, from Andaman, that person has developed rabies. Now what to do, how to manage. And I was a bit surprised that now rabies has reached Andaman, and then they took the history and they found that a month ago that person had gone to Bihar and he was bitten by a dog in Bihar, and then he had come to Andaman. So it was basically infection from Bihar, and Andaman still does not have rabies.
So, but Andaman has dogs now, sir.
Oh,
Andaman,
definitely.
is it they cannot rear dogs or something like that?
No. They have huge number of dogs. I recently went to Andaman, and they have a huge number of dogs, just like any city of the country, like Delhi, and there is no dearth of dogs there.
Okay.
So now, what is the number of deaths in rabies reported from our country? So in 2004, there was a data estimation done which said 20,000 deaths every year. And now the data has changed. There was a latest study published in Lancet just last year, which has estimated it to around between 5,000 to 6,000 deaths. They estimated around 5,700 something deaths in 1 year from rabies in our country. So this is just the tip of the iceberg because rabies is not reported. We are still missing the cases. If you look at the accurate number of reported cases, it is just 289 or something was reported on the government portal. But they have estimated using mathematical models, and they did survey across the country in around 16 states and a lot of districts they covered. So they were able to come up with a figure of around somewhere between 5,000 to 6,000 deaths. And 40% of bites are in children, and they are usually bitten on the face and neck region because of the short height. Now, a question arises, I just answered just 5 minutes before while just preparing for this talk. There was a bite from a rat. Now, do we need to give anti-rabies vaccination? So we should know which animals do not transmit rabies. Number one is the rat from the household. That is the rat bite occurring in the houses. It is considered to be non-rabid. Other than that, rabbits do not transmit rabies. Reptile bites like snake bite or alligator bite or crocodile bite or what you call it, chipkali, what we have, lizard bite, all these do not transmit rabies. So basically rabies is transmitted by mammals, warm-blooded animals. There is a problem with squirrels. There is a case report which was published wherein there was an association between squirrel bite and there was development of rabies. So we are still not very sure with squirrels. What has happened is that around 15 dead squirrels from South India, that is, it was, I think, Kerala and Tamil Nadu and Sri Lanka, they sampled and they found around 15 dead squirrel samples contained the rabies virus. Have they ever transmitted? We do not know. So now what we say is that if it is an unprovoked bite, that is a squirrel comes and bites you, you take the complete treatment. But if you are trying to feed a squirrel with a nut and then you get a nick on your finger or something, maybe you do not require treatment. Bats, India,
Sir,
they are still
what
not.
about bats? Because
Yes.
today morning only I saw a bat bite case in the OP.
Yeah. So in India, bats have not been known to transmit rabies because these are fruit bats. There is a study from Northeast wherein some bats were found to contain the rabies. Dead bats were found to contain the rabies virus. But there is no case report of rabies being transmitted from bats. So till date, we are saying that bats do not transmit rabies in our country. In America, wildlife and bats are the main source. In our country, 99% of cases are because of dogs, and remaining 1 or 2% of cases are from cats, monkeys, and all other animals. Right,
So
sir?
regarding the bats, is it not only the bite? They say even the aerosol.
Yes,
Aerosol
that
is
is
also a mode of
yeah.
transmission.
Yes, so that is Europe, that is America, wherein the aerosols from vampire bats are known to transmit rabies. So that is one of the important causes of rabies in America. So whenever people go into caves which
Yes.
are infested with bats, they are asked to take pre-exposure prophylaxis or post-exposure, whatever the situation may be. Yes, you're
But
right.
today I saw one child, sir, which was exposed to bat inside the home. The parents were very anxious whether to get the ARV, and I just Googled and saw bat bites need ARV. So I advised them to get the ARV. Is it right or not? I don't know.
It's all right, sir. See, they do not cause rabies, but if the parents are so anxious and all that, you can give them vaccines. It will at least act as a pre-exposure prophylaxis. But till date in our country,
logistically, there is no need in your case.
no need, sir, no
No
need.
need.
Till in our country, bat rabies has not been documented till date, so there is no need, sir.
But the parents are very much anxious. That is
I
why.
understand. I understand. So, if you are the treating doctor, they must have told you that why did you not give us pre-exposure prophylaxis beforehand?
Yeah.
So, what I tell pediatricians is that always mention on your vaccination card rabies vaccine advised, and the parents have refused. Because they will say, ki, Doctor, you should have told us beforehand, we would have taken it. We took thousands of rupees worth of vaccines. We could have taken this cheap vaccine earlier itself. So always mention it on the card because it is very easy to blame the pediatrician and you won't remember whom you counseled and whom you did not counsel for pre-exposure. Right?
One point of concern, as we have already discussed, sir, this pre-exposure prophylaxis, we should insist on IAP platform, and then in future we should go ahead, sir.
Sir, it is there in the guideline, ACVIP guidelines. It is mentioned that high-risk population, especially children, should be given in consultation with the parents, rabies vaccine. It is mentioned in the chapter. So we have not put it in the schedule as such because still we are not able to decide at what point to give the vaccine. But yes, any vaccine, the rabies vaccine can be given to a child over the age of say around 18 months to 2 years because only after that he moves out of the house and starts pulling at the ear of the dog and gets bitten. And if you have a dog at home, then you can give it earlier also because kids keep playing with dogs and they keep getting scratched. So you can give it earlier also. So we have given
one doubt, sir.
Please go ahead, sir.
Actually, it's my personal doubt. My daughter.
Doctor, can we have the discussions at the end?
Okay.
We'll
Thank you,
have to
ma'am.
allow sir to have the flow of.
Thank you, ma'am.
Later,
Thank you.
we have time for
you
Q&A.
can, yeah, you can write it in the chat box also. I'll take it in between, no problem. So what I was saying is that in our nursery there was a cat which entered the nursery and scratched 2 or 3 newborns, and we gave rabies vaccine to them. And then there was another case. One of the corporate hospital treating doctor called me up. A newborn's scalp was removed with a swipe by their pet dog. So the pet dog simply swiped over the head of the newborn, and the scalp skin was removed. And then they had to infiltrate and give the vaccine and everything. So yes, there are a lot of. That's what I'm saying. There are so many scenarios wherein you need to give the vaccine and you do not know how to manage because everything cannot be mentioned in the guidelines. So now moving ahead, modes of transmission, animal bites, yes, the most important mode. So these are the ones which cause more than 95% of cases of rabies. But the other cases like licks on abraded skin and mucosa, yes, we treat them as category 3 scratches. So scratches are the same to us as bites. So we do not say that this is a scratch, so therefore nothing much is needed. We say that yes, scratches also can cause rabies, and there are multiple documented cases of scratches leading to rabies because the rabid dogs are salivating and they keep licking their paws. So when they scratch, if they have saliva on their paws, they'll deposit the virus on the wound. Now coming to uncommon modes. The uncommon modes, one of the important ones is aerosol, respiratory transmission. So how does it occur? We as pediatricians keep intubating left, right, and center encephalitis patients. So rabies ultimately presents as encephalitis to us in lots of cases. The previous history is missing, and they simply turn up to our emergencies with altered sensorium. And then when their GCS score falls, we are intubating them. And whilst intubating, we come very close to their mouth and the ET tube, and we put in the tube the way we put in, and we are all exposed to aerosols. And later on, the next day, the grandmother or somebody comes from home and says that this child was bitten by a dog 1.5 months ago or something, and we are in trouble. What to do? Another scenario I'll give you is that we suspected a child to be rabid and was put on ventilator. And when the child died, the consultant was on round. So she said, okay, let us send trifine brain biopsy for Nigeri bodies, and Nigeri bodies came positive. And the whole intensive care unit was up in arms. Now we have been exposed, what to do? Should we take rabies immunoglobulin? Should we take vaccine? What all is to be done? So this is a very common scenario. Once I got a call from Jodhpur AIMS that the residents were hell-bent on going on strike, and they were demanding HRIG with the vaccine because the rabid patient had been admitted in the emergency, intubated and ventilated for 5-7 days. Another case in RML. So this keeps happening across the country. Now the answer to this question is that number one, till date, no resident has died of rabies because of aerosol exposure. We see left, right, and center. One of the PGs develops tuberculosis every year, and some PGs, but no PG has ever died of rabies. And we have intubated thousands of patients over the period of 3 and 3, that is 6 years, but none of us have developed rabies. So aerosol transmission practically is not been demonstrated. Theoretically can occur, but till date no case has been reported. Now, how to manage the outcry from the residents to the nursing staff to the sweeper? The sweeper will come and say that, look, sir, I handled the secretions of the child. The nursing staff will again say that I did suction of the child. So all of these will cause a lot of problems. So best approach is, number one, they should be given pre-exposure prophylaxis, which we know is not very easy to convince our medical superintendents and administrators. Herein, in this scenario, you can give them vaccines, and if they are very panicky, you may give them immunoglobulin also. But again, the statement is that till date, no case has been documented. Next is organ transplantation. So I was just reading an article because we were into publishing a thesis, so we were doing literature review, and there are a series of cases from various countries, right from USA to the recent one was from China around 3 years ago, US in 2016, and multiple other countries wherein cornea transplant and organ transplant have led to rabies and have led to deaths in patients who were recipients of organs from organ donors. So organ transplantation, definitely yes. You should give complete post-exposure if you find out that the organ which has been transplanted is from a rabies patient. Ingestion. This is a scenario which is very common, wherein a whole village comes up and stands at your door, especially in government setups in Delhi, that the cow has died, and they have all taken milk from the cow, and that cow is thought to be rabid. The death of the cow was because it was bitten by a rabid dog, and the cow has died. And there are 15, 20 people or 30 people who have ingested that animal's milk. So what should be your answer? Anybody quickly?
Not needed.
Transmission through milk, it's not needed.
No need, there's no need.
So 2018, from 2018 till 2018, WHO said that if you have taken raw animal milk, you should take complete post-exposure prophylaxis. But studies have demonstrated that rabid animal milk does not contain the virus. So after that, we are saying that whatever kind of milk you have taken from the rabid animal, please do not bother. It will not lead to rabies. So in Delhi recently, around a month ago, I think nearby Delhi, it was Ghaziabad or some Faridabad. There was a case which came in the newspapers also. Some of you must have read that a lady died of rabies, and she was the one who had ingested the animal milk, rabbit cow's milk. And then there was a lot of hue and cry that what happened. Basically, that lady was looking after the animal also. So she was managing the animal, washing the animal, cleaning up the animal. So maybe she had some cut on her hands or somewhere wherein the saliva of the cow came in contact and the lady developed rabies. That is the feeling. So next situation is sexual. Sexual, a adult dies, a male or a female, and the spouse comes and says that I have been having regular sexual relationship with the person who has died. What is to be done? So in this situation, because the families are so much under stress and we do not know if there is a presence of virus in the secretions, the vaginal secretions or the semen, we advise complete post-exposure prophylaxis to the patients because there is already a death and we do not want to harass the family further. Oh, light stops moving. Okay. So now what is the incubation period of rabies? Quick. Chalo, I'll show it because we don't have that much time.
Yes, sir. We have only 15 more minutes time. Sir.
Yeah. So we are very short in time. So the incubation period is from 30 to 90 days. And cases can occur a bit earlier also. We have documented cases occurring by the end of 2 to 3 weeks also, wherein the virus has been directly deposited on the cut nerve endings and can lead to rabies. Yes. Over 6 months, it is less than 1%. So why I'm stressing on this line is that a lot of times it happens when a family comes to you with a dog bite and then you tell him that, look, there should be infiltration in the wound. And then the other mother says that, look, this second child of mine was also bitten by a dog and was not given vaccine or immunoglobulin. What to do? So there are no guidelines as such. Till when can you give immunoglobulin and the vaccine? We say that whatever happens within 6 months. So after 6 months, at least nothing needs to be done. Before that, it is up to you to decide and give the vaccine and the immunoglobulin. And bite on head and face, rabies occurs earlier, that is within a month, and extremities, it may take slightly longer also. So now what is happening is that if you look at the data which was published in Lancet, hardly 5% of the patients are getting rabies immunoglobulin, and only less than 5% are getting rabies immunoglobulin. What is happening is that the patient is advised wound washing, maybe given a vaccine, maybe disinfected, but immunoglobulin is not being given. So these are various case reports wherein patients developed rabies, the one from Assam, another from Aurangabad, one from Bengaluru. So all these patients were given vaccines but were not given rabies immunoglobulin. So if you look at the infectious disease hospital data from Delhi, out of 50 rabies patients in 2023, there were around 12 patients who got the vaccine but did not get the immunoglobulin and developed rabies. So what I'm trying to stress here is that please give immunoglobulin category 3 bites. So this message should go down to all and every person who's managing dog bite. Now, why is it important? Because for the first 7 to 10 days, the vaccine is not able to produce any antibodies. So for 7 to 10 days, you need passive prophylaxis, that is ready-made antibodies must be given, which whatever is available to you for providing protection in first 7 to 10 days. If the virus binds within first 10 days to the nerve ending, then you can do nothing about it. The patient is going to develop rabies. If the virus binds after 10 to 14 days, then the virus will be destroyed by the antibodies produced due to the vaccine which we have administered. So this is the logic. You have to give passive prophylaxis in the form of immunoglobulins. Now coming to categorization of wounds, a lot of confusion is there. To make it very simple, any wound where even a drop of blood or serum oozing out from the wound is seen is category 3. To look at it the other way around, whatever patient reports to your OPD is category 3 until and unless proven otherwise, because hardly anybody comes to you that the dog has licked me, or I just touched a dog, or I brushed against a dog or something of that sort. Whatever is coming to you is category 3. If you are not very sure, take a spirit swab and move it over the alleged site of bite. And if there is burning or tingling at the site of bite, that means that the integrity of skin is broken and it is category 3. So we call it the spirit test or the swab test. Very simple. At the site of bite, take a spirit swab and rub across it. If there is burning, means it is category 3. No doubt about it. Right. So what you need to do is wound washing, infiltration of either immunoglobulins, that is rabies immunoglobulin or monoclonal antibodies, followed by a complete course of vaccination. So now we have, what are the sources of immunoglobulins? We have two main sources, and the third one is the monoclonal antibody. So first is the equine rabies immunoglobulin. Yes, equine rabies immunoglobulin being used across the government hospitals, which is derived from horses. And another is HRIG, which is derived from human volunteers. ERIG is made in our country. It is made in Hyderabad and Pune, wherein the horses are given multiple doses of the vaccine every 10 days, hyperimmunized. Then their blood is removed from their central veins, RBC separated, re-injected to the horse, and from the serum separated, antibodies are again removed by centrifugation, broken up into FC and FAB, and one part is packed and provided to you in vials. HRIG is imported. It was earlier imported from Israel. Israel has said that we are busy with our war and we do not have anything to supply to you. Now we are getting only from China. Earlier, there was another supply from Germany also that stopped long back. So now the only supply of HRIG is from China. It is not made in our country till date. So the dose of rabies immunoglobulin, HRIG is 20 IU per kg body weight. Maximum dose, there is no upper limit. So patient is 100 kgs, you multiply by 20, it becomes 2000. Equine rabies immunoglobulin, the maximum dose is 40 IU per kg. So a 100 kg patient, you have to give 4000 IU. So there is no upper limit. And ERIG must be administered only after a test dose. So this is what is written in the product insert. WHO says that sensitivity testing is not required, but on the PI product insert, the sensitivity testing is still mentioned. Why is it still mentioned? Because it was mentioned 40 years ago when the product was launched, and the pharma says that why should we remove it? Because to remove it, we have to spend a few crores of rupees to do a trial and then send a letter to DCGI that we are removing this statement because this is the result of our study. Why will we spend money when a product is already being sold in the market? So please do not go by product inserts of any rabies vaccine or immunoglobulin. They are outdated. They were made the day when that product was launched in the market 20 years, 30 years, 40 years ago. They are not updated, and the pharma is not ready to update. We have complained to the DCGI also that these PIs need to change as per the national guidelines and WHO guidelines, and let us see how things move. But I'm telling you what is the true scenario, because a lot of rubbish is written in these product inserts which need not be followed. Now, coming to the immunoglobulin, infiltrate as much as possible into and around the wound, and remaining, if any, should not be given intramuscularly, right? Why should it not be given intramuscularly? We will discuss. Inject RIGs into all wounds. So we had a case of rabies. I posted it in all the WhatsApp groups I could access around 4 or 5 days ago, wherein a child from a nearby village, part of Delhi itself, it is not a village which has come into Delhi, was bitten by a dog, multiple bites. Around 7-8 places the dog bit the child. That child reported to a medical college, which is nearby to my residence. And they calculated the dose and they injected half the wounds, left remaining half because the RIG was insufficient to cover all the wounds. So if the child is around 10 kgs and you calculate by 40, it comes to 400 IU. 400 IU means 1 ml has 300 IU. So 1.3 ml is the total dose calculated. So with that, you cannot cover all the 7-8 wounds. So they infiltrated 2-3 wounds, left the remaining wounds, and the child developed rabies and died. And there is a lot of hue and cry, and investigations are going on. I am also a part of the committee. So inject RIG into all the wounds. Now you will say that what to do if the number of wounds are more and the quantity is less? You dilute it with sterile normal saline. Do not exceed the dose. If you exceed the dose, the vaccine is going to be suppressed. So we do not exceed the dose. We dilute the RIG with normal saline. How much can we dilute? You can dilute it 10 to 15 times, no problem. So that is the way we do it. Presently available preparations are very safe. So whatever preparation you have in your supply, you use it. They are all very safe. So now this is the pathogenesis slide, which will explain why we do not want to give rabies immunoglobulin IM, because the virus is present locally at the site of bite, and it multiplies in the locally in the muscle fibers. There is no viremia. So when the dog bites you on the thigh, the saliva is deposited there, the virus is deposited there, the virus enters in the muscle, either lies dormant or starts multiplying, and from there it binds to the neurosynaptic junctions and then ascends to the brain, right? So if you give it IV or IM, sorry, not IV, IM, if you give it, the immunoglobulin will go through to your all of your body, will reach the site of bite, but not in sufficient concentrations to neutralize the virus. So to neutralize the virus, you need to give it locally. So that is the reason we are saying that please do not give it IM, do not waste it IM, give it at the site of bite, right? So now the question arose was that one wherein I have said that you give the immunoglobulin only at the site of bite, and other side I have told that you give it 40 IU per kg. So ultimately, dena kitna hai, how much is to be given? So we thought let us estimate the volume of equine rabies immunoglobulin required for local infiltration in soft tissue animal bites in children using a wound size based approach. So what we did was we measured the size of the wound and we gave the immunoglobulin locally, and we estimated the amount of infiltration done in 100 patients per centimeter of the wound. So this is what we got. So if the wound is 1 centimeter long, you need approximately 0.75 ml per centimeter, right? So normally there are scratches or linear wounds which have only a length, no breadth. So you give it 0.75 ml per centimeter. Whereas if the wound has an area that is length into breadth, then you give it 3.18 ml per centimeter squared. That is again an approximation that you give it 3.18 ml per centimeter squared. So wound is 2 centimeter over 2 centimeter. It comes to 2 to the 4. That is 4 centimeter squared. So you give it 4 3s are 12. So 12 ml will be required. So 0.75 ml per centimeter and 3.18 ml per centimeter squared. So these are the two formulas you need to keep in mind. And the remaining regression equations, I know you are busy practitioner, you will not be able to remember. So just these two are sufficient for you. So just a video to show how infiltration is done, very important. So you go from outside the wound to just below the wound and you inject and withdraw the needle. That is the way it is to be done. It is a very painful process, and I have seen a lot of vasovagal syncopes occurring. Please use a pair of goggles also, so that you cover your eyes, because sometimes what happens is a spurt from the needle comes onto the person holding the child, and then there is a problem ki ab kya karna, what to do now. So this is another patient. The number of bites you can see in this child is 1, 2, 3, 4, 5, 6. So there are 6 wounds and you need to infiltrate all the wounds. So you just go below the wound, just below the wound, and push, infiltrate and withdraw the needle. It's that simple. And you can use a 26 gauge needle also. Herein we are using a 24 gauge needle. You can use a 26 gauge needle also for infiltration. No need for a thicker needle. It's a very simple process, very painful, and let the patient lie down comfortably, because again, as I said, that I have seen vasovagal syncopes occurring in these patients because of the pain. Moving ahead. So now problem was of equine rabies immunoglobulin was that the supply was limited. You needed to inject the horses, and ultimately it is an animal product derived from animals. Then HRIG was very costly, and then there was a potential risk of bloodborne pathogens being transmitted. Then there was a problem of type 3 anaphylactic reaction with equine rabies immunoglobulin. Skin sensitive testing was another problem. So WHO said that, okay, let us have a product which has been made artificially and which does not require to have all these issues. So it said that because we are only able to cover less than 1% of animal bites. So this is 2002. Now it is we are able to cover only 5%, but at that time hardly less than 1% were receiving rabies immunoglobulin. And we need an unlimited supply, which should be cheap and easily available and standardized. Let us have a product from various universities and CDC Atlanta, USA, and ADRI Ottawa, Canada. So these two were the universities which were selected. Other universities also had some molecules, but these two were selected and given to a pharmaceutical to mix both the monoclonal antibodies and come out with a product. They took two different countries, so the problem of patent would not arise, because if there is a problem of patent, the product will cost you 1 lakh rupees and nobody will be able to afford it. So with this, the product which was developed was known as TwinRab. It is a monoclonal antibody that contains two monoclonals, tocaravimab and miromavimab, that bind to site 2 and 3 of the G glycoprotein. The dose is again 40 IU per kg, same to the equine dose. No skin sensitivity is required and is recommended by WHO, CIAP, that is ACVIP, and our association, Consortium Against Rabies. So this is a product which is now available in the market for last 4-5 years. And another product which was developed is known as Rabies Shield. This is from Serum Institute, and this contains single monoclonal antibody. The earlier one had two, and this contains single monoclonal antibody. This is again available in the market, and the same, no skin sensitivity required, and the use is recommended by WHO and ACVIP and Consortium. All three of them approve its use. The dose is 3.33 IU per kg. So the dose here is different. Please remember, 3.33 IU per kg, whereas TwinRab was 40 IU per kg. I'm not discussing the reasons for the difference of dosages, but here you can see 40 IU per kg and 33 IU per kg. The rest, everything is nearly the same. Now coming to vaccines, how much time? 5 minutes more, or I should move quickly, sir? All the vaccines, as far as we are concerned, are the same, because there are either purified vero cell vaccines or purified chick embryo vaccines available. As far as we are concerned, all are the same. They are all 1 ml, other than IndiRab, which is half ml, produced by Bharat Biotech. Routes of administration, intramuscular, intradermal. We all know, most of you are using in government setup intramuscular, in private setup it's intramuscular. It is 037-14-28. The day 0 is the day on which the first dose of vaccine is given. Gluteal region should not be used. If somebody has given the vaccine in gluteal region, don't count it. Consider it invalid and repeat the dose. WHO has reduced the dose to 4, that is 037, and 1 dose between 14 to 28. But in India, we are still persisting with 5 dosages. Somebody who has received prior post-exposure prophylaxis, for life, he just requires 2 doses of the vaccine, day 0 and day 3, and does not require rabies immunoglobulin. For first 30 days, for first 90 days, he is protected and he requires nothing. The 90 days begins from the first day he received the vaccine. So for first 90 days, he is prepaid. He does not require anything other than wound washing if there is a repeat bite. And after 90 days, you require just 2 doses, day 0 and day 3, no rabies immunoglobulin, and this is lifelong. A lot of people say 5 years, 10 years, 15 years. No, it is lifelong for us and our patients. Intradermal route used by government setups across the country. It was notified in 2006 by DCGI, and we are all using ID route in our setups, that is government setups. And the one vial which is reconstituted can be used till 1 session, that is 6 to 8 hours. And storage is all simple, same everything, nothing different. Schedule is 037-28. So day 14 we are not giving. So it is 4 visits as per NCDC and Government of India guidelines. ACVIP also says the same thing. WHO has reduced 1 more dose from it. So WHO says 222, that is 037 only. But we are not following this. Why I'm telling you this is, a lot of times there will be questions that WHO is saying only 3 shared doses, wherein we are saying 4 doses. Intradermal again, be careful, this is intradermal. IM it was 5 and 4, intradermal it is 4 and 3. right? So this is the WHO regime is known as IPC, Institute Pasteur Decompose regime. I will not discuss in detail because time is short. Technique is important. Bleb has to be raised. If the bleb is not raised, please repeat it nearby site. Pre-exposure prophylaxis 0728 is the one which we are following. And again, same. After exposure, no immunoglobulin and 2 doses of vaccine, 0 and 3. Day 0 and 7, two-site ID regimen has been approved by WHO and ACVIP, and my publication just came out 3 days ago, wherein we did a study on 2 days 0 and 7 in children, and we got 100% results. So you can use this schedule also. Now, just 2-3 more slides. What we want, how do we eliminate or eradicate or control rabies? So the better word would be control of rabies is mass dog vaccination is the only way available to us now. Goa has achieved 0 rabies, and in Tamil Nadu, Chennai also has done very well and is reporting 0 rabies over last some years. This is because of the mass dog vaccination, wherein if you are able to cover 70% of the dog population, the transmission of rabies amongst dogs and to humans stops. So that is the easiest way for us to prevent rabies to be transmitted to humans. Other options are wildlife vaccination, animal birth control measures for dog population control, and management of open waste disposal, garbage dumps, open drains where dogs thrive. So basically, One Health approach is the only way to eliminate rabies from the country, because rabies is ultimately a zoonotic disease. It is coming from animals to humans. Humans are not transmitting to humans. So you control it in the animal world, rabies will no more be there in the humans also. So this is what is known as One Health approach. So a collaborative effort between humans, animals, and environmental health sector. So I will not discuss anything else, and we move to summary. That is
diabetes.
most cases.
Dr. Yashoda, please.
Yashoda ma'am, your
Dr. Yashoda, please mute yourself.
Dr. Yashoda.
Dr. Yashoda, please mute.
Oh, now she's gone mute. So most cases reporting to our OPDR category 3. In case of any doubt, take a spirit swab and move it over the skin surface. If there is burning, tingling, you take it as category 3. Use any RIG, but use RIG. Recombinant monoclonals are the future, which are cost effective, safe, and available in unlimited quantities. No role of IM administration of rabies immunoglobulin. Awareness is the key to prevent rabies deaths, and One Health approach is the need of the hour to eliminate the disease. So these are some posters. It's in Hindi. We display outside our rabies clinics, so people sitting there can know what to do. Now we have beautiful emergency trays. This is just a tray containing all the emergency drugs. This is the wound washing area, which I wanted to show. This is an area we developed. It has a pedestal, and then there is a jet, toilet jet you can see, wherein you can wash your wounds on the legs. So somebody is washing wound on the leg. Child is washing wound on the leg. Infiltration being done by our nursing staff. She is infiltrating the face of the patient. A beautiful bleb being raised on another child, and the child is showing his bleb. And let us end rabies together by 2030. Thank you so much.
Thank you, sir, for that
you,
very
sir.
nice presentation. And there are lots of questions in the chat box. I will just
Before
immunoglobulin.
This was A to Z presentation, A to Z, covering all aspects. Wonderful.
All about rabies.
Thank you,
That's
sir.
the heading, sir.
Wonderful.
Immunoglobulin or monoclonal antibodies, which is better?
Monoclonal antibodies are something which are being used by pediatricians in the private sector for last 7-8 years. There is no case of failure which has been reported from monoclonal antibodies, and the incidence of reactions is also very less in monoclonals. Although the equine product which we have also is now very much purified. But yes, there is a fear of type 3 hypersensitivity reaction later on, and you can give equine only once in lifetime. So in other situations wherein you may need equine antibodies, for example, snake bite. So for snake bite, the ASV is again produced from horses. So these are all equine products: anti-diphtheric serum, anti-snake bite serum, and anti-rabies serum. So I think monoclonals should be better, slightly costlier as compared to equine, but can be used more frequently in private setups. In government, equine is available freely, so we are still persisting with equine. And whenever there is a reaction to equine, we give monoclonal antibodies. HRIGs are no more available in good supply and very costly. For an adult like me, it will cost me around 35,000 rupees to take the complete course. So nobody is ready to afford it. So I think monoclonals are good. We can go with monoclonals.
Very well.
Sir, monoclonal antibodies are freely available now, sir?
Yes,
Yeah,
yes.
yeah, they are freely available
Freely available.
with your
100
vaccine
100
What is the
supplier.
IU.
cost, sir? Cost-wise?
Cost is about 2,500 to 3,000 for
Okay.
100 IU. 100 IU is what is needed for a 30-kilo child. Sir said
Yes.
3.33 international units per kg.
Per
So
kg,
that,
yeah.
So
yeah,
one
that
vial
is,
for a 30-kilo child.
yeah,
Okay,
that is
thank you.
Rabies Shield, and then there is Twin Rab, which is 40 IU per kg, which is also costing you around same amount, and that contains 1 ml, contains 600 IU, and
Okay.
it is a 2.5 ml vial. So there are two products. One which Madam is saying, Rabies Shield,
Rabies Shield.
3.33 IU per kg, 100 IU per 2.5 ml, and Twin Rab, which is 1 ml contains 600 IU and 2.5 ml vial. So that is 1500 IU per vial. Product is also available. So you can use any, both are good.
Sir, just as we were through this lecture, I just received a call from one of the corporate hospitals outside. This is an 11-year-old child. 5 days back, he was bitten and there was a category 3 bite. He had been to the government hospital. I think over there he's received equine immunoglobulin and they've initiated ID, that is intradermal ARV. So 2 doses were given, day 0, day 3. Today
Yes.
is day 5. Today, the child has been once again bitten by another dog. This is also category 3 bite.
Okay. So you will have to give him immunoglobulin
Yes,
again
so this
because
time this is immunoglobulin. Now they have come to a private hospital. So now they've not gone to government hospital because it is not available 24/7. Only tomorrow morning they can go. So they've come to a private hospital. So in equine immunoglobulin, we cannot give for the second time now, sir.
no. In this patient, you can give second time because it is just 5 days. You can give monoclonal
No, but
antibodies
now
also, no
that's what. Now
problem.
we advise monoclonal antibody.
Yeah, no
It is to
problem,
be
no problem.
diluted and all the wounds to be infiltrated. That's the
Yes,
main
you will
thing.
have to, but
And
a
continue
problem.
with the government schedule because once they come outside, doctors outside usually are not very good about this intradermal, which is the
Yes.
2 doses. So go back to government hospital for continuing the 7, 14 and 28 or 7
You
and
can,
20.
so you can change the route to IM and continue with the IM schedule if he wants to come to you, or he can go to government back to the intradermal route. But there will be a problem here. What has happened is that his dose will get exceeded. You understand? He
Yes, sir.
received immunoglobulins before and immunoglobulin now. So the dose will get exceeded. So there is a risk of vaccine getting suppressed.
Okay,
So
sir.
ideally in this child, you should get antibody titer done at day 14 and day 28, ideally.
Ideally for antibody. So where do they do the antibody titers?
So there is a Metropolis lab in private sector which does it. We do it at Maulana Azad, but we do it more in research mode.
No,
And
mostly
then
these
there,
veterinary people, they do their antibody titers and they take boosters once it goes down below that
yes.
threshold level.
So Bangalore, there is Dr. Rita Mani's lab which is doing it. Then NIV Pune is also doing it. So there are a few labs. The techniques are different. Dr. Rita Mani and NIV Pune are doing refit, whereas Metropolis and we do ELISA method. So you can get it done, ideally speaking, or what you can do is you can give him a day 90 booster
Yeah,
also,
that's what the
because the
extra dose.
yeah, because the problem
Dr.
is that
Anurag,
the
Dr. Anurag, that was an excellent presentation, A to Z presentation. This is regarding the spirit test, Usually any abrasion, when you apply spirit, it got some hyper secretion or burning secretion. How we really it is the hyper anesthesia or it's a tingling sensation?
Yes.
How we differentiate?
So you no need to differentiate, sir. If there is a burning sensation, it
Burning
means
sensation.
your integrity of skin is broken. So it is a category 3 bite. Simple.
So the split test is only meant for the testing the integrity of the skin.
Yes.
It is
If you're
applied
not
at the
sure.
wound site. At the wound site. Applied at
Yes.
the wound site.
So if you're not sure of the categorization,
But normally any abrasion, if you apply spirit, you will get burning sensation. You know, sir.
yes. So it is category 3, na, sir. Any abrasion, if you apply spirit and it leads to burning, it is category 3. You cannot have a situation wherein you say that the virus is lying there quietly and will multiply after 14 days only. So after your vaccine takes effect.
And
So if
one
your
more
integrity of skin is broken, you have to give the immunoglobulin. And to find out if you are not sure, you apply the spirit. If you are sure, if there is visible bleeding, nothing needs to be done. Simply wash the wound.
One more question which we have already discussed in the forum. During the febrile illness, what we can do, sir, for the vaccination?
You will have to continue with the vaccination. There is no way out for you. It is a killed vaccine, so it does not get suppressed with the routine febrile illnesses.
That's a message I wanted from you to send it to the listeners.
Because sometimes we have day 0, 3 and 7th day when they come, the child is running a temperature of 100, 101. They want to
So
postpone
in
the
spite of
vaccine.
fever, you have to continue with the
Yes. This is one situation you should not postpone.
Yeah,
you
that
should
is
not
correct.
postpone.
I
Sir,
can
there is one
acknowledge the
situation.
presence of
Sir.
our past president, Dr. Balashankar, in the place.
Sir has asked a question. Dr. Balashankar has
Sir, one
asked a
small
question.
clarification. Please correct me if I am wrong. The split test is to differentiate between class 1 and class 2, sir. I think it is for that only, not class 3.
Yeah, actually, what you are saying is not wrong. It in literature, if you see, it is mentioned that if your spirit test is positive, it is class 2. But you have to understand the situation that this was written long back when immunoglobulins were not freely available. And what we say as experts is that you cannot have a scenario where the virus is there, but it is not binding to the nerve ending, or it will bind after 14 days. So when you give the vaccine takes 2 weeks at least to give your antibody titers. So what we say is either you have the virus or you don't have the virus. You cannot have that kind of a scenario. So forget that category 2. It is if you ask me personally, category 2 should not be there. You should have category 1, 3, and there should be another category which is 4. I'm not discussing it. Discussion will go long. So we experts feel that spirit test positive, consider it category 3. We have seen cases of rabies occurring on scratches also, simple scratches.
So
There
better
was
to
a
err
case
on
in
the
Yes,
side.
better to give it than not to give. There was a case from Shimla wherein a lady was simply scratched by a pup, not even a big dog, a pup, and she developed rabies. It was a simple scratch, a category 2, which you would like to call it. So don't
Sir,
take risk and give it.
Sir, one simple question. We are getting a puppy today in our home, new puppy to our home. What we have to do, sir? We have to get a pre-exposure prophylaxis, sir?
So yes, now what has happened is that if you go to a veterinarian, he will say that puppies will be given vaccine only after 3 months of age. You tell him, you tell him that you give the vaccine today. We will bring him back at 3 months. You give another dose.
Sir,
See,
not for the puppy. I am asking about the family
yes.
member.
So both. I'm taking both because this is also important.
Okay.
And you should give the family a pre-exposure prophylaxis complete regime to all the family members, because these pups are prone to scratching and biting and causing lot of simple small scratches playfully also. And then the family is in so much of stress what to do. So everybody should take the vaccine, the whole family and the dog.
Okay. Thank you, sir.
Is there a concept of carrier in animals still there?
Dr. Balashankar was asking, is there a concept of carrier in animals?
So carrier stage is there. Definitely in the wild animals, jackals and all that, dogs and cats are not known to be carriers officially. As per standard books, dogs and cats are not known to be carriers. Other animals in the wild are known to be carriers wherein the virus survives. That is the official statement. But my personal feeling is dogs can also act as carriers. It is my personal feeling. It is not there in the literature. So please don't quote me. That is the truth. Because lots of dogs who have not received antibody vaccines are found to show antibody titers. When studies are done in dogs and day 0 sample is taken for some study or something, the dog has not received the vaccine but is found to contain antibody titers. Where are they coming from? We do not know. So there could be abortive rabies, there could be carriers, we do not know.
Sir,
one
I have
personal
given,
question, sir.
so a person who has taken first time 5 doses, second a year later, they had a that is one more exposure. So 0.3 was given. 3
0.3
years
only.
later, I've given 0.3. Like that, how many 0.3 is lifelong? That's what you said. That's
Yeah.
what you said.
So
I've
this
given
is
3 such courses. 3
Ha,
such
ha, ha,
courses.
ha. So don't worry, I have the same problem in my family. My daughter, she gets bitten by dogs because she goes and puts her hand in the dog's mouth, and the dog one fine day closes the mouth, and then she comes to me, Papa, I have been bitten. So you know what happens is, number one, you have to modify either the behavior of the dog or the person. See, a dog frequently biting means that person is going and fingering the dog unnecessarily. So my daughter is the same. She goes and fingers the dog. And second scenario is the dog is abused. If this it is the same dog which is biting, means that dog is abused by some people, and you need to take care of that. Now, how many times can you give 0.3? If you look at data, 0.3 given once or twice, the titers persists for 10 to 20 years also. So, ideal world, you should get an antibody titers done, and if it is less than 0.5 IU, you should go for vaccine. But again, if you
But
go for
that is not
antibody titers,
practically possible.
it is not
It is
practically
difficult,
possible.
sir,
The
to
cost
get
is,
that done.
yeah, cost is 5,000 rupees. Will give you a report after 3 days, and your vaccine costs 350 rupees.
Yes, sir.
So maybe you can give it 3, 4 times, and
I've
then
given
ask
3
the
times
person to,
max so far.
yeah, modify the
Ask the
behavior.
person to be careful. I always,
Yes,
in my OP, if any person comes to my in a year more than 3 or 4 bites, I will warn them. I will
yes,
tell the police and put you behind the bar.
yeah,
They
they have
buy
to be
pizza.
careful. They are
They
unnecessarily
buy pizza
irritating the
and
dog.
so many other things for 350 rupees. So
Anurag sir, one practical questions. I am
Yes,
living in my road. There are 2, 3 families. They are nurturing group of dogs,
yes,
street
sir.
dogs.
Mhm.
Average on an average, 4 to 6 dogs are there
The
in
street.
different, various apartments. Usually, when I'm going for a walk, I used to take a sticks.
Mhm.
How do I control or how do I approach this nurturing people about it because of the Animal Protection Act is there? Is there any way of controlling this crowding or nurturing by a private people?
I think Sar is asking about, is there any law to control
Yes, yes,
dogs
I
in
know.
the
I understand, sir.
in
This is
a
a daily
society?
problem. Yeah. So now, see, I'll tell you the practical aspect again. These people who feed dogs, they are known as animal lovers, and I also too love dogs, and I'm not anti dogs.
Sir, one
Uh,
incident, I can see some persons throwing
huh,
biscuits daily,
yes,
particular time in their bazaar. In the bazaar,
and
they
and
are
you
throwing
cannot do
biscuits.
anything about it because they are so well organized that they will send you a notice from the court if you try and oppose them feeding the dogs. The court guideline says that any person who feeds the dog has to take responsibility of getting the dog immunized, neutered, number one. Number two, there should be a separate feeding area away from the places where children play, wherein the dog should be fed. It should not be in the open anywhere they feel like. So that is what the law says. If your society or your RWA has the gumption to fight with these people, you can definitely tell them, ki, look, you are feeding the dogs. We have the society common camera videos available. We can go to court. We can go to the police and complain against you. Or you you have design a feeding area and go and feed the dogs there. You cannot feed the dogs anywhere you feel like. But again, you need a lot of grit to fight these people because they have one lawyer somewhere who will immediately send you some kind of a legal notice, and 99% of us go away quietly who will fall into the fight with these kind of people. So this is the only way out for you. Otherwise, there is no sense in removing dogs. You cannot remove dogs. Dogs are territorial animals. As per law, you cannot remove dogs. If you remove them unofficially, the dogs from neighborhood areas will come and take over the area. And whenever you have a new dog in the area, there is a lot of fight between the other dogs. That dog is aggressive, is frightened, and there are more incidents of biting. So we say that please do not remove the dog. Vaccinate the dog, neuter the dog, and feed the dog in a private area. Do not throw stones or anything at the dog because the dog gets abused and then it becomes aggressive and is afraid of people and can jump and bite. So that is the only way out for you, sir.
Thank you, sir.
Thank you, sir. That was a lot
So
and lots about rabies.
yeah,
And,
there is a question: a chicken was bitten by a rabid dog, and people ate the chicken. Nothing to be
No.
done because you don't eat raw chicken. You cook the chicken first.
Similar things with the cow's milk also. Cow was bitten
Yeah,
by a
that's what
dog.
already
And,
sir has told.
So
yeah.
that we have already discussed.
So it won't. Oh yes. Thank you, sir.
Yeah. So thank you
Sometimes
so much. I think
we get from the zoo, visited the zoo, monkey bite. We get
yeah,
monkey
monkey bites
is
is
one
a
of the
problem.
quick
Yeah,
wire.
same treatment, ma'am.
Same
Same treatment.
treatment. Yes,
Morning
sir,
walk you
that's
go and monkey jumps on you, bites you. Everything is same. But treatment remains the same.
Yes, sir.
Thank you, Nandini. We will close it.
Yeah, yes, sir. Sir, thank you very much.
If you
Thank
want,
you.
there are some questions in the chat box. If you want, I can answer them.
Yes, sir. You can.
If a dog bites within 90 days of PREP post-exposure, not needed? No, not needed.
Yes.
After 90 days, you need it. But if you have taken the 2-dose post-exposure, 0 and 7, then this 90-day rule does not apply. 3-dose, 90-day rule applies. Sir, can we use Dettol only or can give mediolateral thigh in young children? What is this? Deltoid. Yes, you can use any site you want to for intradermal administration, no problem, because intradermal, you're talking about intradermal
No,
or
sir.
IM?
Intramuscular.
Intramuscular, yes, the anterolateral thigh is not a problem. You can give it. Anterolateral, not mediolateral. Can monoclonal antibodies be given in OPD setup or should we? You can give it in OPD setup, no problem. They do not cause reactions. Is there, if you are giving vaccine to any person in your OPD, then you have an emergency kit with you. So you can give monoclonal antibodies and vaccines in the OPD itself. So you should have an emergency tray for whatever injection you are giving. It could be a chickenpox vaccine, it could be a DPT, pentavalent, whatever you are giving. Is there any time limit for immunoglobulin? As I said in my presentation, that within 7 days of getting the vaccine, you can give immunoglobulin. After 7 days, the antibodies produced by vaccine take effect. Second part, maximum upper limit, if he has not received vaccine or immunoglobulin, maybe it is 6 months, not written anywhere in the literature. This is what we feel as experts because less than 1% cases occur after 6 months. So it is not required. Not written anywhere in literature. So please don't ask me to give you reference for it. The more I hear on rabies, I come, thank you so much. And in dog rights are more than human safety, sir. We cannot remove them from their place of origin. Definitely, a carrier dog was kept in Kunuru. Yes, dogs can be. As I said, standard books tell you that dogs are not carriers. They die within 10 days. So that's why the observation period of dogs and cats is 10 days. But I personally believe dogs can act as carriers. So that is the situation. Thank you so much,
What is
ma'am.
the schedule
What
for
if they come
pre-exposure
after
prophylaxis?
day 8, sir? They come because immunoglobulins are indicated till day 7. Suppose somebody comes only on day 8. Can we initiate the vaccine immunoglobulin? Can it
Yeah,
be
so
initiated?
the day 7 cutoff is when you've received the vaccine, within
Okay,
7
sir.
days of getting the vaccine.
No, somebody comes, a bite took place earlier. They just poo-pooed it. They just thought nothing. Then suddenly they heard rabies is very fatal. And then they come to you only on day 8, saying that I was bitten 8 days back and it was category 3. Blood was seen. I just washed. I didn't take much. Now I'm getting scared. People say you should have taken the vaccine.
Yes, you can give. So that's what I'm saying. You can give vaccine and immunoglobulin till 6 months.
Okay.
But if you have taken only vaccine, so
Okay.
that is day 7 cutoff. So
Okay.
if you take what happens is a lot of times people take vaccine from the local chemist and they receive 2-3
Dr.
doses,
Nandini,
and then somebody
we
takes
can
you,
wind
it is
up.
category 3, go for immunoglobulin also. So for that, the 7-day cutoff is there.
Okay, sir. Okay.
Dr. Nandini, we can wind up.
Yes. Yeah. Thank you. Thank you very much, sir. And thank you to all the speakers. And thanks to TNSC, Kongu Pedicon, Curtain Raiser, CME for all the 6 resource persons for this excellent talk. And I think rabies, we went on and on because there's so much doubt about rabies with many of the people. Thank you, everybody. And thanks to all the people who logged in. Thank you all. And
thank you. I can acknowledge the presence of Professor Subramania sir also.
Yes.
Thank you, sir. Thank you
Yes,
for
yes, sir.
attending.
Yes, sir.
Thank you so
Thank you.
much, friend.
Bye.
Thank you, sir.
Thank
Thank
you.
you
Bye,
for
sir.
having me.
Anurag, sir,
Bye,
bye.
sir. Bye.
Thank you
Good
very
night.
much.
Thank
We
you.
will
Good
meet you
night.
soon in
Wonderful.
Kongu
Good night.
Pedicon, sir. Thank
Thank
you.
you.
Wonderful.
Thank you,
you.
Devendra, sir.
Thank you,
sir.
sir.
Thank you. Thank you. Thank you, Anurag. Thank you.
Thank you, sir.
Thank you.
Good night. Good
Bye.
night. Good night. Good night.